Good afternoon, and I'm going to call to order the Assembly Committee on Health and Human Services. I'd remind members to please turn on your cameras and mute your microphones unless you are speaking. And Madam Secretary, please call the roll.
Assemblywoman Benitez Thompson. Assemblywoman Black. Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews.
Here.
Assemblyman Orenlicker. Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong. Assemblywoman Thomas.
Here.
Assemblywoman Titus.
Here.
Chair Nguyen.
Here. And we do have a quorum, and I will note for the record, Assemblywoman Black, I see her, so she is present. I don't know if her microphone wasn't working or if she just didn't hear her name called, but I do see her present. And I would ask that Assemblyman Orenlicker, when he arrives, if we can mark him present. I know he's currently presenting in another place. And the same with Assemblywoman Benitez Thompson and Assemblywoman Summers Armstrong. I will try to catch them, and hopefully my vice chair will also be able to do that. I know that a lot of you are just receiving your lunch, so I understand if you need to eat it. We need some energy for today, or if you want to turn off your camera because you don't want everyone seeing you eat. I just ask you when you're done, if you could turn it back on, that would be great. And with that, we do have a quorum, so I am going to get started. I am going to take a couple of things out of the order from the agenda, just because of the nature of people being in different places and presenting in different committees right now. But I will start with one of our bill hearings. And so the first bill hearing that we are going to start with is Assembly Bill 430. So at this time, I am going to open the hearing on Assembly Bill 430. This bill revises provisions relating to disabilities. I know that she has an extreme interest in all things health and human services, and as a last-minute appointee, I know that she does spend a lot of time watching our committee. So welcome, Assemblywoman Brown May, to Health and Human Services, and I would ask you to begin when you are ready.
Thank you. Thank you, Chair Nguyen, Vice Chair Peters, members of this committee. You are absolutely right, Chair. I do love this committee and have not been able to spend as much time watching. So luckily everything is recorded, and I appreciate all the work that you have been doing. We are very pleased to be here today to present Assembly Bill 430. For the record, I am Tracy Brown May, representing Assembly District 42 in Clark County. With me today is Jessica Adams, and Deputy Administrator of the Aging and Disability Services Division of the Department of Health and Human Services, and Ace Patrick, Chair of the Nevada Statewide Independent Living Council. So today we are working to raise awareness about the importance of using preferred words and phrases to refer to people with disabilities and to update our Nevada revised statutes. As I testified in another committee just a few days ago, the meanings of words change over time, and as society evolves, we must also make changes to reflect that evolution. In this session of the legislature, we've had the opportunity to consider a number of bills intended to raise awareness and improve equality. I know that you've already heard one bill brought by our minority leader, which is the joint resolution to effect the changes in our Constitution. The words and the labels that we use in statute can have a profound effect on people. Now, this bill was first discussed during the interim. The Statewide Independent Living Council members identified the use of the R word that continued to exist in Nevada revised statutes. And while the reference is to an association, that association does not exist in Nevada today, and we are working to eliminate that outdated language. There are also a number of references in NRS 435 that are inaccurate and offensive to people with diverse abilities. And at this time, I'd like to turn the presentation over to Jessica Adams, our Deputy Administrator of Aging and Disability Services, and she will walk us through the bill. When Jessica is completed, then we're going to turn this over to Ace, and Ace can give us a little bit of perspective of what it's like being a member of the disability community.
Thank you, Assemblywoman Brown May. And I'll just remind presenters to please clearly state their name before they speak so we can have a clear record.
Good afternoon. I am Jessica Adams, Deputy Administrator for Aging and Disability Services Division. Thank you to Chair Wynn, the committee, and Assemblywoman Brown May for having me here today to help present AB 430. So I'm going to walk through the bill. AB 430 does revise obsolete terms and phrases within NRS 435 regarding the care and services provided to persons with intellectual and developmental disabilities. The proposed changes will align the language used in NRS 435 with the language and phrases already used within developmental services and the community. So Section 1 revises NRS 435.060 to describe the transition of persons residing in a residential facility for groups to a non-facility-based setting from being able to live in a more normal situation to being able to reside in an appropriate community-based setting that is not a facility. Section 2 revises NRS 435.115 to remove a reference to the State Association of Retarded Citizens and the board, as this organization no longer exists in Nevada. And as Assemblywoman Brown May mentioned, that is an offensive term now. So it will just be changed to that the fee schedules will be established by the Administrator of Aging and Disability Services, subject to the approval of the Director of the Department of Health and Human Services. Section 3 revises NRS 435.130 to update the Declaration of Legislative Intent for Jobs and Day Training Services. This will change the purpose of jobs and day training services for people with intellectual and developmental disabilities from providing the services to help them become useful citizens to providing jobs and day training services to increase independence. This bill has no fiscal note. And again, all of these changes align NRS 435 with terms and phrases that are already used within the developmental services field on a daily basis and represent current terminology, as well as the respectful language deserved by the people that we serve. And on that note, I will pass it over to Ace Patrick.
I think we need to unmute. Oh, there we go.
Thank you. Good afternoon. My name is Ace Patrick, and I am the chair of the Nevada Statewide Independent Living Council. Thank you, Madam Chair. Thank you, Assemblywoman Brown May, and committee members for the opportunity to provide some background information about the importance of our words. Since the late 60s, there has been an evolving movement towards person-first language. It originated in Sweden and began to be incorporated into the United States with some historical acts within our Constitution. Now it is the current accepted terminology of the American Psychological Association, the APA, that further translates into most government acts such as the ADA, Americans with Disabilities Act, and the IDEA, the Individuals with Disabilities Education Act. It only makes sense that Nevada ensures our language in statute follows suit. The purpose behind person-first language emphasizes the individuality, equality, and dignity of people with disabilities by maintaining that an individual is a person first and foremost, and that their traits and medical conditions do not define who they are, but rather are simply that, a trait or medical condition. Using person-first language reduces social stigmas and provides a frame of reference that places all people in the same category before introducing any other aspects to be considered. Although not every person agrees with person-first language, it generally invokes mutual respect and is appreciated by the majority of the disability community. As the chair of the Nevada Statewide Independent Living Council, I am speaking on behalf of the council when I say that Nevada Silk chooses to educate and inform any and all who may question the purpose or meaning behind this movement, and supports person-first and respectful language options for people with disabilities. The most important thing to remember when considering person first language is that it replaces some very antiquated and offensive terminology that has no business in Nevada language. Words do matter. In my experience, I can testify to the fact that for years, I felt like a farm animal being herded by doctors, psychiatrists, and institutions while they used my diagnosis as labels to push me through to the next provider. I don't think these professionals started to see me as a person until the paradigm began to change, and suddenly I became a person with autism, a person with hearing loss, a person with blindness, a person with a neurological disorder. My life changed dramatically when professionals began to address me about my diagnoses and not talk to each other about my diagnoses as if I didn't even exist. It may not seem like it matters to people who have never had to remind others that they are in the room, but I can tell you that it has made an enormous impact on the quality of my life. I am a person with disabilities, and I support these important changes proposed in Assembly Bill 430. I want to thank the committee for bringing it forward. It's 12:31.
Thank you. And this time I will go back to Assemblywoman Brown-May.
Thank you, Chairwoman. That is the crux of our position and our presentation today. As you can see, the words we're working to eliminate are words that isolate us from each other. And so we're really just trying to eliminate the misunderstanding that exists. The three words we focused on are normal. According to everything I've been taught, normal is nothing more than a setting on my dryer and should not be used when describing people. The word retarded, which is a diagnostic term and should not be used to describe people, and then to insinuate that we are helping people to become more useful is just insulting. And so those are the three terms we're focusing on eliminating in this bill. We thank you and we urge your support for this bill. Thanks very much.
And I'm looking around here. Do we have any other questions? And I will note that Assemblywoman Benitez Thompson had popped on, but I see that she has popped off, but she was present here for a while. Do we have any other questions from committee members or comments? I think that's a hand from Assemblyman Hafen. Go ahead.
Thank you, Madam Chair. And Assemblyman Brown-May, I just want to say thank you for bringing this forward. I know we've had other bills and resolutions to clean up obsolete language that in today's day and age we just no longer use because it's not appropriate. So I thank you for that. I did have a question in regards to the I know there's a national ARC association, and would the changes have any effect with any interaction with the National Association?
Thank you for that question, Assemblywoman Brown-May, for the record. Assemblyman Hafen, through you, Chair Nguyen. The National ARC Association is, just as you stated, a national affiliate organization. And at one time, there was a national affiliate here in Nevada. That currently does not exist. Changes in this bill would not preclude that from happening. And if there was an advocacy organization that was so intended, could nationally affiliate with the ARC of the U.S. And I know that the Division of Aging and Disability Services and our leaders there would be very happy to work with the National ARC. Currently, the ARC is not involved in the fee setting schedule in Nevada, so it would not really have any impact here at all.
Do you have any follow-up questions, Assemblyman Hafen?
I do not. Thank you, Assemblywoman Brown-May, and thank you, Chairman.
Do we have any other questions or comments from committee members? Seeing none, at this time I will go to, do you have any, I'm sorry, Assemblywoman Brown-May, I should ask this, do you have any callers on the Zoom in support of the bill today?
Madam Chair, I don't believe we have anyone on Zoom. We do know that we will have a couple of callers we're expecting on the telephone.
Okay. Broadcast services, at this time, can we begin testimony in support of Assembly Bill 430?
Testify in support of Assembly Bill 430. Please press *9 now to take your place in the queue. Would the caller with the last three digits 688 please slowly state and spell your name for the record? You have 2 minutes and may begin.
Yeah, my name is Troy Frieden, Troyfriden. Thank you for taking the time to listen to my public comment. I'm the Chief Operations Officer for Chrysalis. Chrysalis provides services for over 220 people with intellectual disabilities in Nevada in support of the living arrangements and/or jobs and day training settings. I want to voice my support for Assembly Bill 430. This legislation will enhance the dignity of some of Nevada's most vulnerable citizens by updating antiquated language and statute that's perceived as demeaning and/or alienating. It will ensure that the NRS focuses on person-first ideology. It will also make the language in the NRS more compatible with federal regulations, including the Home and Community-Based Services Settings Rule issued by the Centers for Medicare and Medicaid Services in 2014. I'm very thankful to the state's commitment to serving this wonderful population of citizens. In particular, I'm grateful for this legislative body's ongoing commitment to this population by considering legislation such as AB 430. I also want to thank ADSD Administrator Dina Schmidt, as well as Deputy Administrator Jessica Adams for their leadership and partnership with providers and serving individuals with intellectual and developmental disabilities. Thank you.
Thank you for your testimony. We can go to our next caller and support broadcast services.
Would the caller with the last three digits 177 please slowly state and spell your name for the record? You have 2 minutes and may begin.
Thank you, Madam Chair and committee members, for allowing me to speak in support of this important bill. I'm Lisa Foster, and I represent SNAP, the State of Nevada Association of Providers. SNAP organizations provide supported living arrangements, jobs and day training, and related supportive services throughout the state. AB 430 moves the Nevada statute language into the modern vernacular for individuals with intellectual disabilities. Removing the term more normal situation in Section 1 to what we now have and what our providers offer, appropriate community-based settings, demonstrates what is truly most helpful for the individual SNAP serves. And SNAP appreciates also the removal of the word retarded citizens from the statute in Section 2 and the change to increase independence from useful citizens in Section 3. The terms are antiquated and less than respectful. We greatly appreciate Assemblywoman Brown May for bringing this legislation forward. Thank you.
Thank you. If we can go to our next caller and support.
Chair, we have no more callers in support at this time.
Do we have any callers in opposition at this time to Assembly Bill 430?
To testify in opposition of Assembly Bill 430, please press star 9 now to take your place in the queue. Chair, we have no callers in opposition at this time.
Do we have any callers in neutral?
To testify in neutral to Assembly Bill 430, please press star 9 now to take your place in the queue. Chair, we have no callers in neutral at this time.
And with that, I will turn it back over to Assemblywoman Brown May for any closing remarks.
Thank you, Chair. We just would like to thank you for your time and your consideration of Assembly Bill 430. We appreciate the time that you've taken today to hear it and know that our stakeholders are very grateful. I want to thank the administration, Jessica Adams, and everyone who's worked really hard on this bill, the Center for Independent Living. So thank you for your time and your energy today.
Thank you. And with that, I will close the testimony on Assembly Bill 430. I know that we will probably, I know a lot of people have asked if we could pass this today just for ease of moving stuff along. I will put this on for a work session on Monday, so we will be seeing this very shortly. So thank everyone on the committee for your support of Assembly Bill 430. I'm sure that Assemblywoman Brown May appreciates that, and I'm glad that we were able to bring this bill. I know that it was inspired in part by the conversations that we had with Minority Leader Titus's AJR that we heard earlier in the session. So with that, I will close that. I know that we are waiting for people that are going back and forth, and we do have a pretty lengthy presentation on Assembly Bill 347. So I want to make sure that we have opportunities. I know that Assemblyman Ornlicker, I believe, just speed went through another bill hearing in another department, and so, or another committee. But if we can take just a 2-minute, I'm going to say 2-minute recess, just to make sure that we can give time for transition. I'm going to make sure we can get all of our members back on here to do this quick work session for these 2 bills that are on, and we will come back. So again, a 2-minute recess just for a minute to see if we can get people on.
Chair, we are unmuted and you may begin when ready.
Wonderful. Thank you, Gall. I will note for the record that Assemblywoman Summers Armstrong is now present with us. We do have 11 members present, so we do have a quorum. At this time, I am going to move into our work session document. It's a pretty quick work session document. First up, we have Assembly Bill 358. And if I can turn this over to Mr. Ashton to summarize the bill.
Thank you so much, Chairman. Would you like to start with AB 358 or 273, just to clarify?
358, please.
Okay. For the record, Patrick Ashton, Committee Policy Analyst of the Legislative Council Bureau. Just a reminder, as nonpartisan staff, I can neither advocate nor oppose any measures that you will consider today. So we heard Assembly Bill 358 on March 29th. This bill requires the suspension rather than termination of eligibility for Medicaid of a person who is incarcerated and enacts certain other provisions as summarized in this work session document. I also wanted to mention that Director Richard Whitley of DHHS provided a memorandum today that followed up on questions that were raised during the bill hearing. The memorandum was sent to members by email and is also available on Nellis. Madam Chair.
Thank you. And at this time, I will see if there are any the committee has any questions. I'm looking on here. Any big hands if you need one? Seeing none at this time, I would entertain a motion on Assembly Bill 358. And again, we are taking those out of order, so I just want to melt that to our committee. It is Assembly Bill 358.
So moved.
Thank
Second.
you. I see a motion from Vice Chair Peters, a second from Assemblyman Hafen. Madam Secretary, do I have any comments on the motion? Seeing none, Madam Secretary, will you commence a roll call vote?
Assemblywoman Benitez Thompson. Assemblywoman Black.
No.
Assemblywoman Gorlow.
Yes.
Assemblyman Hafen.
Yes.
Assemblywoman Krasner.
Yes.
Assemblyman Matthews.
Yes.
Assemblyman Orenlicker.
Yes.
Assemblywoman Peters.
Yes.
Assemblywoman Summers Armstrong.
Yes.
Assemblywoman Thomas.
Yes.
Assemblywoman Titus.
Yes.
Chair Nguyen.
Yes. And with that, the motion carries, and I will actually assign that floor statement to myself. Next, if we can go to our next bill on work session, that is Assembly Bill 273. Mr. Ashton, if you could summarize this bill and any amendments.
Thank you, Chairman. For the record, Patrick Ashton, Committee Policy Analyst. We will have now Assembly Bill 273. We heard this bill on March 19th. This bill creates a statewide mental health consortium to represent existing regional mental health consortia. The bill prescribes the membership and duties of the statewide mental health consortium and allows the statewide mental health consortium and each regional mental health consortium to request the drafting of one legislative measure within the scope of the statewide or regional consortium as applicable. We have here an amendment. Dan Musgrove, on behalf of the Clark County Children's Mental Health Consortium, proposes to amend subsection 4 of NRS 433B.333 to first, remove the requirement that the administrator of the Division of Child and Family Services or the deputy administrator of the division serve as member of the consortium, and second, instead require the administrator or his or her designee to serve on the consortium. Please see also the attached proposed amendment. Madam Chair.
Thank you. And do we have any questions from committee members? I know that there were some amendments that were posted on Nellis. I know that the bill sponsors reached out to this committee, but are there any questions at this time? I see Assemblywoman Titus. Go ahead.
Thank you. It's not actually a question, it's just an acknowledgement. I had concerns with this bill and the membership of the committee, concerned that members may be able to sit on different committees, and recognizing that the volunteer world is somewhat limited and people with interest is somewhat limited and their capacity to be able to fill this board. It's been my understanding that that's been clarified, and since this is not a governor-appointed board, that members, it doesn't interfere with some of the other roles that potential members may have. So I just wanted to make sure that that was clear on the record, and that answered my concerns. So thank you, Madam Chair.
Thank you. I appreciate that you reached out to the bill sponsor and legal to get that answer. Do we have any other comments? Seeing none, I would entertain a motion at this time to amend and do pass.
So moved.
I have a motion by Vice Chair Peters. Do I have a second?
Second.
I have a second from Assemblywoman Titus. Do we have any comments on the motion? Seeing none, Madam Secretary, will you please take a roll call vote?
Assemblywoman Benitez Thompson. Assemblywoman Black.
No.
Assemblywoman Gorlow.
Yes.
Assemblyman Hafen.
Yes.
Assemblywoman Krasner.
Yes.
Assemblyman Matthews.
Yes.
Assemblyman Ohrenlicker.
Yes.
Assemblywoman Peters.
Yes.
Assemblywoman Summers Armstrong.
Yes.
Assemblywoman Thomas.
Yes.
Assemblywoman Titus.
Yes.
Chair Wynne.
Yes, motion passes, and I will send that floor statement to Assemblywoman Gorlow. And with that, that concludes our work session. And at this time, I'm going to go ahead and open the hearing on Assembly Bill 347. This bill revises provisions related to health care. Due to the complexity of this bill, this presentation will take a little bit longer than usual. Additionally, I've given Zoom access via the video conference to certain stakeholders to testify on this bill, both in support, opposition, and neutral. And we will kind of set this up a couple of different ways. I know Assemblyman Ohrenlicker, we have talked about this coordinated effort to make sure that we have like a thorough policy discussion about Assembly Bill 347. And so likely what will happen is we will have a presentation, the main presentation for Assembly Bill 347. We will take testimony in support, opposition, as well as neutral. I have allowed for certain key stakeholders to have an extended opportunity to testify in opposition. And then I will actually open this back up for questions again. So questions after the main presentation, testimony, and then we will open it back up for questions again from members with some of those people, key stakeholders, to be able to answer any additional questions, and also for Assemblyman Ohrenlicker and his presenters to also respond. I think it will lead for a more fruitful conversation and debate about this policy going forward. And I appreciate everyone's, ability to read this. I know it is very complex. I know we tried to have some stakeholder informational meetings at the beginning of session that hopefully this kind of triggered some of those for those people that are not familiar with the healthcare world. And if not, this will probably give you a bigger knowledge base to be able to process this particular policy. And so with that, I will turn this over to our very own Assemblyman Ohrenlicker, and go ahead when you're ready.
Thank you, Chair Wynne, and thank you for giving extended time for this discussion. So I'm just going to try to get my slideshow working. And we're almost there. Okay, So thank you, Chair Wynn and members of the
Before
committee.
you begin, Assemblyman Ornlicker, broadcast services, can we make sure that this is going, I can see it, but can we make sure that it is being broadcast to the public as well?
Yes, Chair, this is broadcast and we can see the slide.
Perfect. Go ahead and begin when you're ready. Sorry to interrupt.
That's okay. So thank you, Chair Wynn and members of the committee. For the record, I am David Ornlicker, representing Assembly District 20 on the east side of Las Vegas, from Paradise to Henderson. I'm here today to present Assembly Bill 347, which includes two proposals to make our healthcare system much fairer for patients and also for doctors, hospitals, and other providers of healthcare. Assembly Bill 347 will make healthcare fair for them, and it will make it more accessible for patients, especially minority and poor Nevadans who struggle now to get the care they need. I'm joined today by co-presenters Joseph White, Jolette Goins, Casey Kristen, and Asia Duncan. And this bill is for the Medicaid recipient who can't find a primary care physician because we don't pay doctors enough under our Medicaid program. With this bill, Medicaid patients will be able to get care sooner in a doctor's office rather than later in an emergency department when they are much sicker. This bill is for doctors, hospitals, and other healthcare providers who do treat Medicaid recipients and lose money doing so because our Medicaid program underpays providers of healthcare. This bill is for individuals who can't afford to purchase healthcare insurance because premiums are too high. This bill is also for people who have healthcare insurance but can't afford the deductibles or co-payments when they seek care. This bill is for workers who don't get wage increases because their employers have to spend more and more money funding employee healthcare benefits and less on salary. This bill is for small businesses that can't afford to offer healthcare benefits because healthcare premiums are too high. This bill also is for businesses who do provide healthcare insurance because the bill will reduce their healthcare costs and make them much more competitive with businesses in other states. This bill will make healthcare more affordable and accessible for the many Nevadans who struggle to get the healthcare they need today. The proposal is based on careful study and consultation with health economists and policy experts across the country, including many of the stakeholders who participated in our working group. Special thanks to Joseph White from Case Western, who you'll be hearing from, who developed the idea that we're presenting in AB 347 in the second part of the bill, and Natalie Johns, who's been working with me for 3 months on this and doing terrific work to get us to this stage. So, as I said, we've had a working group for a long time now. We've included stakeholders from across the spectrum, hospitals, other providers, insurers, employers, unions, patient advocates. We've had formal meetings for the past 2 months and individual meetings since December, actually, and we're continuing with meeting with smaller groups to get their perspectives. And as you see, we have several things in our conceptual amendment that reflects the input from our stakeholders. And we're careful to make sure that they had the framework for the bill 2 months ago. A month ago, they got the actual language of the bill and then the final formal bill a couple of weeks ago. So the motivations. First, Medicaid reimbursement rates in Nevada have been too low for too long. It's unfair to Medicaid patients because it impedes access. If we don't pay providers enough, they're reluctant to take care of Medicaid patients. So it's unfair to patients because of the inability to find providers. And it's unfair to providers as well. We undercompensate hospitals, physicians, and other caregivers. And it's just not fair. It also results in cost shifting. If we underpay on the Medicaid side and doctors and hospitals are losing money, they have to raise their reimbursement rates for privately insured patients to make up the difference, and that raises health insurance premiums. So it's unfair to everybody when we underpay Medicaid. Our payment system is too complicated if we look on the private insurance side. Too many negotiations over rates. Providers have to deal with multiple insurers, negotiations with each one. Too much variation in rates, and I'll show you some examples. But you may pay $5,000 in one hospital and you might pay $30,000 in another hospital. Too little transparency in rates. We don't know exactly what their negotiated rates are, and it's a mystery trying to figure out how much you're going to pay if you've ever looked at a hospital bill and tried to figure that out. Too much distortion of market forces. We have, in some markets, insurers have too much leverage, and in other markets, hospitals. And it'd be nice to have a free market in healthcare, but we don't, because the market just doesn't work in healthcare the way it's supposed to. So some providers are underpaid. We've seen definitely in Medicaid, but even in the private side, it's tough to make a go of it as a primary care doctor in many places. And some providers are overpaid. And that causes our healthcare system to be far too expensive. So to illustrate how high the problem of high healthcare costs, United States, we spend about $10,500 per person on healthcare. The next highest is Switzerland, which is just under 70% of what we pay. It's $7,000. And Germany is 57% of what we spend. Canada is under 50% of what we spend. Japan, 45% of what we spend. And New Zealand, 37%. And it's not because you don't get you get very good care in Switzerland, Germany, Canada, Japan, and New Zealand. So we're overspending on healthcare. Why are we spending so much? Why are our healthcare costs higher? Well, it's not because we go to the doctor more often or spend more time in the hospital. We actually go to the hospital less often. We spend less time in the hospital. We don't see doctors as often in Japan or other countries. It's not because we're sicker. We're actually, on average, there's less overall sickness in the United States than than Western European countries on average. And that's because we have a younger population. We don't smoke as much as in Europe. So it's not because we're sicker. It's not because we're more litigious. We may be more litigious, but that makes the cost of the tort system account for less than 1% of our healthcare costs. So that's not the reason. The reason why our costs are higher because our prices are higher. You get an MRI in Japan for $150. Here it's $1,500. And the reason why our prices are higher is because we rely on insurance companies rather than the government to negotiate. Every other country, well, maybe Switzerland doesn't do quite the extent, but France, Germany, Canada, Japan, New Zealand, all these other countries that have lower healthcare costs than we do, the reason why they do is because the government negotiates the prices, and the government is just a much better negotiator than insurance companies. So here's an illustration, the difference between getting an appendectomy in Nevada and getting one in Taiwan. So if you look at the blue line at the bottom, the horizontal flat line, this is the cost of getting an appendectomy in Taiwan. And you notice it doesn't matter where in Taiwan you are. It's the same price, and it's about $2,500. You get an appendectomy, have your appendix out in Nevada. Well, the best price, $3,500, is 42% higher than in Taiwan, and it goes up from there. So whether you're in the north or the south, makes a big difference. And the highest price, and this is from the Public Employee Health Benefit Plan, this is what their negotiated rates in Nevada for state employees. The highest is almost $48,000, 1,800% higher than in Taiwan. This makes no economic sense. It's not because this $47,000 appendectomy is a better appendectomy. It may be worse. There's a very poor correlation between quality and cost in the United States. And we should be where Taiwan is. And no hospital in Nevada is where Taiwan is. So the goals of this bill, AB 347, to ensure that providers are fairly paid for both publicly and privately insured patients. Fair compensation is what this bill is about. No undercompensation and also no overcompensation. So we want to protect against excessive charges to patients, because that's a real problem in our country and in our state. We want to simplify the health care payment system because it's hopelessly complex. As I said, nobody really knows what the costs are. Hospital executives don't even know what their hospital pricing is. And we also want to preserve vital private market virtues. I majored in economics in college. I believe in markets. I want to have a market, but sometimes we have market failure. When the market fails, government has to step in and correct. And then decrease the administrative burdens. You probably have heard many times that all the paperwork that providers have to deal with, and that's a big reason is because they deal with different insurers with different rates. We can simplify this in very important ways. So here are the principles: fairness. Ultimately, we want a system that's fair for everybody. So we make it fair by raising Medicaid reimbursement rates to address the unfair underpayment of doctors and other healthcare providers. It's not fair to underpay them. And then on the private side, set physician and hospital fees so that providers can cover their costs and earn a fair and reasonable profit. That's a very important obligation, that they cover their costs and earn a fair and reasonable profit. We just don't want them to earn excessive profits. No gouging of patients. And simplicity. With the state setting fees instead of insurers, we no longer would have the complicated and inefficient system of rate negotiations between health insurers and healthcare providers. We just have one set of rates, just like Medicare does for people over 65. It's much simpler. Everybody understands what the rules are. Patients can know what they're paying. Providers can know what they're going to earn. And as long as we set it at a fair level, we have a system that works for everybody. The other thing, for the rate setting commission, the bill will instruct them to start with Medicare rates as a starting point. And then from there, in situations where Medicare underpays, then the rate setting commission can raise the rates to fair rates. But it's very important to start with Medicare rates because it's the best we have in terms of estimating what it really costs for doctors and hospitals to deliver care. Medicare has by far the best data. Nobody comes close. And if somebody can show me a better set of data, we'll put it in the bill. But there isn't anything that's better than Medicare. It's very carefully thought through. It's not perfect, but asking the commission to start from scratch would make no sense. It's like if you want to buy a house, you could hire an architect and a contractor and start from scratch on an empty lot. But it's a lot easier to buy a house that's already out there that may be 90% of what you want, because Medicare gets to about 90% of a fair rate. And then for that final 10%, maybe you need to repaint the house or redo a bathroom. But that's a lot more sensible than starting from scratch. And that's what we want this rate setting commission to do. So first, there are two parts to the bill, and now I'll start going through the provisions of the bill. Part one is the provider tax. So the idea here is we want to raise Medicaid payments to Medicare levels. And the low-hanging fruit here, because I know we have a very tight budget, where are we going to find money to raise Medicare reimbursement rates? Well, what we do with skilled nursing facilities and other states do with other healthcare providers is you say to providers, if you let us impose a tax on you, for every dollar you give us, we will get $2 back from, actually it'll be more than $2. We will more than triple what you give us. So think about that return on investment. Triple what you get, and that's guaranteed, it's not speculative. And we will follow the model from Senate Bill 509 from 2017. The bill does not mandate the tax. It says to providers, if you like this idea of giving us $1 and getting $3 back, If you like it, you can vote on it. If 2/3 of you and if 2/3 of hospitals, you get a hospital tax. Well, that's through Senate Bill 509. If 2/3 of doctors vote, you get a doctor tax, and you triple your money. So that's how that works. The benefits, this will have fair treatment of patients and providers because with the increased dollars, we can raise Medicaid reimbursement rates to fair levels, basically what Medicare pays. And it reduces the need for cost shifting to private insurance. And we have some guardrails in Section 7 of the bill. So one thing is that the dollars from the tax have to be used to supplement rather than replace Medicaid dollars from general funds. Won't be possible now that we have this new source of funding for us to say as a legislature, well, we'll just reduce our general fund contributions to Medicaid. Can't do this. We have to maintain our existing funding of Medicaid. This is to add on to what we're currently funding. And so if funds remain at the end of the fiscal year, if we overestimate the tax or underestimate how much has to be paid out, then funds will carry over to the next fiscal year and not return to general fund spending. The money can only be used to increase reimbursement rates for providers. And in the conceptual amendment, we've added a provision to say that if the legislature does change the allocation of funds, does try to divert funds, then the providers get to revote on whether they want to continue with the provider tax. Okay, so that's the first part, getting Medicaid reimbursement to Medicare. The second part is the rate setting. They say we have to increase Medicaid rates to be fair. We have to lower in some situations private fees. So the principle here is to cover reasonable costs plus fair and reasonable profit. Every provider will get fair compensation under this bill. And that ultimately is the right thing to do, to make sure everybody gets fairly paid. So, and that means primary care doctors who have maybe squeezed by insurers and aren't paid enough even on the private side will be able to maintain their practice and not have to sell out to a hospital or a private equity firm. The rate setting commission is required to meet this standard of fair and covering costs and fair and reasonable profit. It's not an option. As I indicated, to avoid duplication of effort, we'll start with Medicare and adjust from there, just to make sure we don't reinvent the wheel in Nevada when somebody else has put a lot of time and a lot of hard work into figuring out how to get close to fair compensation. And for providers who think the Medicare rates are unfair, as I said, on average, Medicare comes to about 90% of hospitals. They can come in and say, here's where Medicare is underestimating what we need to cover cost and reasonable profit. Just show us the books and we'll adjust accordingly. An independent commission will set the rates. Under our proposal, originally we were going to have it done by Health and Human Services, but feedback from stakeholders persuaded us that it makes more sense to do it as an independent commission. So that's in the conceptual amendment. And we'll have a broad range of stakeholders participating as well as representation from Health and Human Services. And examples of factors the commission will use in setting rates will be the payer mix, right? Because some providers will see more Medicaid patients, some will see more private patients. So to overall cover costs and get a fair and reasonable profit, some providers will need a higher reimbursement rate. Disparities between primary care and specialty services. For a long time, we have underpaid primary care physicians. That makes it difficult to have good access to a primary care physician. So we want to address that, make sure that they're fairly compensated, and also across specialties. Some specialties are underpaid with respect to others. We want to fix that. We want to reward quality of care and efficiency of services, so that would be taken into account. Some providers have seen a sicker population of patients, and it costs them more to do that, so that should affect their reimbursement. We want hospitals and providers to have a population health focus, and so under our current system, often you lose money trying to prevent disease and maintain the health of your population. So we want to reward that. So people will invest more in population health. To the extent there would be financial hardship from reducing rates, because even if people have been overpaid, they've built their system on that basis. So we want to phase any changes in that would cause financial hardship. And we want to protect the workforce and quality jobs. One of the things we want to make sure is hospitals, if they have to reduce costs to meet a fair reimbursement, that they don't take it out on their workers. Okay, as I say, covering reasonable cost plus fair and reasonable profit. Are we there? We're not there yet. That's why this bill is so important, because there are providers who earn more than a reasonable profit. So we have data on our short-term acute general care hospitals, the ones you're familiar with as major, the hospitals you go to the emergency department when you're sick, or that if you need heart surgery. And if you look at those, these are data from most of the hospitals in our state, the major general care hospitals. As you can see, the profit margin ranges from a low of 1%, so that's too low, that should come up, but it goes up to a high of 23%. That's too high. I don't know exactly where the right number is, but it's not in this part of the graph. So we have some ways to go to get to that, covering reasonable costs and earning a reasonable rate of a fair profit. Okay, what will be the impact on the private insurance market when we adopt rate regulation? We'll get lower premiums because we're going to have fair costs and not excessive costs. Fair pricing will lower premiums, and also we'll have greater competition in the insurance market, because it will be easier for new health insurance companies to come in and offer plans, because right now insurers have to create networks based on price discounting. They say to doctors, if you want us to send our patients to you, you have to give us discounts. But with the state setting rates, there won't be any need for price discounting. In fact, price discounting will be prohibited because we have to protect doctors from insurers that try to drive below the fair rate. So we'll have greater competition in the insurance market. That will help lower premiums. It will be similar to the Medicare Advantage program. Medicare Advantage is the private insurance side of Medicare. You can go into traditional Medicare when you sign up and just go to any doctor and, traditional, and the doctor bills Medicare, or you can have Medicare pay your premium for a private insurance plan. And that's a very robust market. When I put in my zip code for Medicare Advantage, there were like 10 or 11 insurance companies with over 40 plans. It's a very robust market. And what's important about it is Medicare Advantage plans all use a common reimbursement structure. They're not required to, but they in fact do. They all follow the Medicare fee schedule. So even though they don't compete, they don't negotiate rates with doctors, they still are able to compete with each other and have a very active, thriving market. So the private insurance market will do very well under this plan, as it does in the state of Maryland, where they have pretty significant rate regulation. I've covered some of the conceptual amendments. We've got some others. Remove hospitals from the provider tax provisions because they're already in Senate Bill 509 from 2017. They don't need to be here. Here's an important thing that probably the most important part of the conceptual amendment. And this is, if physicians or other providers opt for the provider taxes that come in as a group, then that will freeze the medical malpractice non-economic damages cap at $350,000. This is a tweak here, just to Medicaid rates will be raised to the upper payment limit. We say Medicare rates, but more properly, we should say upper payment limit, just to conform to Medicaid rules. And if there's not a Medicare rate, then average commercial reimbursement. That's a small tweak. The rate setting commission will publicly disclose all rates. We need transparency. Where we have opacity right now. More time for the rate setting process. We had a short time frame in the bill but especially for the first year, they'll need the new rate setting commission will need time to get up to speed. So we'll have a longer time frame in year one. This is a small thing, and then adding the provision to protect workforce and quality jobs. Okay, so just to sum up, and thank you for your allowing me the extra time. AB 4347 will improve access to health care for Medicaid recipients. It encourages more Nevada physicians to see Medicaid patients, more care in physicians' offices, less in emergency departments. It provides simplification for providers and insurers, reduces complicated, difficult negotiations between providers and payers. It's a hassle and a headache for everyone. Providers will not have to manage different rates for different payers. And it will increase provider supply in Nevada. By raising Medicaid reimbursement to Medicare levels, Nevada will become a much more attractive state in which to practice. Not to mention the freezing of the medical malpractice non-economic damages. Okay, it will reduce healthcare premiums with increases in Medicaid reimbursement, less of a need for providers to shift costs to private rate pay insurance, and rate setting will protect against excessive charges. That means it will lower costs to the state budget, because a big cost to our state budget is the health insurance cost for state employees. And this will reduce that and bring substantial savings to the state budget, far more than the cost of setting up this independent commission. And it will target regulation and market failure. Right? As I said, I major in economics. I believe in markets, but sometimes the market doesn't work properly. We've been waiting over 40 years for the market to fix itself in healthcare. It hasn't, it won't. We need the government to come in and correct the market failures. This bill does so without the heavy hand of over-regulation. So thank you very much. Thank you for the extra time. And I now will turn over the discussion to Joseph White.
Does that mean I should talk now?
Yes, make sure you state your name for the record before you speak. And go ahead when you're ready.
Okay, my name is Joseph White. I am the Luxembourg Family Professor of Public Policy at Case Western Reserve University. I'm not one of your constituents, but I should say that I've been coming to Nevada since 1972, when my sister moved there in 1971, and she is a constituent of Representative Anderson, Assemblywoman Anderson. And she's also, sad to say, because she's elderly and not that healthy, a dual eligible person. So I care about her Medicaid. Thank you for the opportunity to testify on behalf of this legislation, which would directly address the problem of costs of medical care in a way that no other state has attempted, but that is also normal in other rich democracies. I want to emphasize, I did not develop this idea. I have written more about it than most U.S. health policy scholars have, but I've written entirely from observation of what other countries do. What we're talking about here is something that is essentially the main way that costs are controlled in most other countries compared to the United States. So I'd just like to emphasize a few points in support of Assemblyman Orentlich's presentation and be happy to elaborate by responding to questions. The United States, as he showed, has by far the highest medical care cost per capita in the world. And I want to emphasize that while we are very unusual for our coverage problems, for the fact that we cover roughly 90% of our population instead of 100%, we are more unusual for our costs. We basically have costs that as a share of our economy are about 50% higher than any place else in the world, in the range of 18% of the economy compared to 12% in Switzerland. And so in this way, the costs are actually a more impressive problem if you compare to other countries. And it also means that healthcare is less affordable even for middle-class persons who by American standards are well insured. So if you're thinking in terms of, what is the big problem for your voters? The bigger problem for your voters is the cost of insurance, the cost of healthcare for people who have insurance, not the cost of healthcare for people who don't. That is a really big problem for those people. But the unaffordability of healthcare for people who have insurance is a major, major crisis in the United States, and it's getting worse all the time. So the question is why our costs are so high, and there have been over the years various theories about this, mostly emphasizing in the past couple of decades the volume of care and a claim that there was a lot of unnecessary care. But any comparison to other countries makes clear that the US pays more because our prices are higher. And that the prices are higher in part because our insurance system generates much higher administrative costs that are incorporated into physician and hospital costs, and in part because of the costs of insurance premiums related to the same administrative costs. The problem, as he showed, isn't only that prices are high, but that they are extremely varied. And that means that both insurers and medical care providers have extra costs, first, in keeping track of all the different prices and all the different contracts. Second, in negotiating all the different prices and all the different contracts. And just as an example, I was once giving a talk in Paris about the American healthcare system. And I said that the Cleveland Clinic has 1,600 doctors, and everybody went, ooh, ah. And then I said it had 2,000 billing clerks. And people looked at me in just bewilderment. Why would you need 2,000 billing clerks? And that's the kind of variation, kind of thing going on. There are various estimates of the excess costs associated with our billing system and our payment system. They have to be at least 5% of total spending and probably much more. And I should say that in my written testimony, I provide links to various sources on all this. And the variation in prices is also a severe problem. The US system for establishing prices involves, as Dr. Orentlicher showed, wide variation in what each hospital charges to different payers, either insurers or individuals, for the same services, such as a colonoscopy, huge differences in what different providers charge to the same payer, and then the surprise medical billing, in which we can go to a hospital that is in network and get a huge out-of-network bill from an anesthesiologist or emergency room physician or other provider that doesn't actually work for the hospital. And it's important to emphasize that if prices are standardized in the way AB 347 would create, surprise bills will disappear. Moreover, so would the incentives to create narrow networks. The main reason for narrow networks is as a bargaining technique for insurers. They seek lower prices from providers by threatening to exclude physicians or hospitals from the covered lives, that's the term, that insurers offer them or provide for them. The much higher prices in the United States show that this, what is called selective contracting, actually doesn't work very well at all. But it also creates confusion and difficulty for patients who just want to go to the doctor or hospital and get help without huge expense. And it's really, really hard I think it would be hard to overstate the irritation and the hassles associated with the narrow networks and with the uncertainty about what's covered and what's not, and whose care is covered and what's not. What AB 347 would create is a version of what in the literature is called an all-payer system. In an all-payer system, there are multiple insurers, but all or almost all pay each provider by the same rules, and this massively simplifies billing and payment. It accomplishes most of the savings that could be associated with a single-payer system, or so-called Medicare for all. There are versions of all-payer systems in many countries, such as Germany, France, the Netherlands, Belgium, and Switzerland. It also, again, as Dr. Orentlicher showed, is how Medicare Advantage works. Private Medicare Advantage insurers pay hospitals Medicare prices, and this wasn't something the law explicitly tried to do, but it did it sort of by accident, because the law requires that providers outside of a medical advantage plan's network charge the standard Medicare fees for out-of-network care. This was to protect Medicare beneficiaries in case they had to go out of network. But because the out-of-network plans have to accept Medicare fees, there's no reason for an insurer to contract with an in-network plan and pay more than Medicare fees. So they basically pay the Medicare fees. And as Assemblyman Orentlicher showed, there's actually a lot of market competition in Medicare Advantage between the insurers. And we're talking, here about basically AB 347 combines that, proposes that that Nevada combine price setting with independent insurers in a way that already applies to over 60 million Medicare beneficiaries, 24 million of whom are in Medicare Advantage plans. And it takes the simplest approach to setting rates. Start with Medicare's rules and then deviate if the physician group or hospital can make a reasonable case. For example, as in Medicare itself, with its indirect medical education expenses and its disproportionate share of hospital payments, there may be arguments that a hospital has extra costs from teaching or from a disproportionate share of uninsured patients. And if the Medicare extra payment is not enough, that may justify higher fees. Now, providers will argue that Medicare payments are inherently inadequate. And that's partly because they've worked with they basically make their costs fit whatever money they can create, and they have a great deal they can get, and they have a great deal of market power to get money for all sorts of things, some of which many of us would not think are useful, like some of the salaries of administrators. One should be skeptical about the claims about Medicare payments being inadequate for a few reasons. One is that the Medicare Payment Advisory Commission, MedPAC, analyzes payment adequacy very carefully. And if you want, you can look at the methodology in Chapter 2 of the annual reports. The most recent one came out a couple of weeks ago. Second, the proposed payment reform should substantially reduce hospitals and medical groups' costs through the savings from simplification of billing. Third, the proposed payment reform would increase income through raising Medicaid fees to the Medicare levels. And while some of that would come from the provider tax, much more would be a new subsidy from the federal government due to the Medicaid matching percentage. So even if right now the Medicare payments are arguably a little lower than they should be, which MedPAC will normally deny, it remains the case that there's going to be substantial savings to providers and new income to providers from this bill. So really, the Medicare payments would have to be off by some meaningful amount for them to be actually inadequate. Now, nobody should imagine any reform will work perfectly, but the approach used for AB 347 is straightforward and relatively simple. We should remember that versions of all-payer rate setting have been implemented successfully around the world, and that most other proposals for controlling healthcare costs involve far, far less positive experience and evidence. I could direct you to a huge amount of stuff that was actually in the Affordable Care Act and that the healthcare policy wonks have been proposing over the years. And in fact, none of them have a comparable track record to the record of administrative simplification and rate setting, both rate setting and rate simplification that we see in other countries with all-payer rate setting. So thank you for your consideration, and I am happy to try to answer any questions.
Thank you, Mr. White. If Assemblyman Orlicker, I believe you have a couple other people. Are they on to be a part of your presentation, or are they on for supportive testimony?
Thank you. They're on for part of the presentation. So Jolette Goins, Casey Kristen, and Asia Duncan.
Okay. I will ask all three of those individuals to please turn on their cameras. And I will start with Ms. Goins because I see her up first. It looks like there's some technical difficulties.
Okay, there we are.
There we go.
Good morning. My name is Jolette Goins. And I wanted to speak about, or more or less, I guess, tell a testimony personally, how the strain that the healthcare, our healthcare policies have been personally. And my interest in the bill is because of, hope that maybe some of these things can be eradicated. Okay, I'm a senior. I live under a modest income. I work 3 days a week and I get Social Security. But I do have health care. I have health care from my job. I pay, but I think it's a crazy amount for it, but we have to have health care. and also when you're 65, after 65, you're required to have Medicare. So I'm covered by, I have two insurances. I have coverage by two insurers, which I'm thinking, okay, good. I'll be able to, take care of myself, be healthy, whatever. But I go to the doctor and get a diagnosis. They give me a plan for recovery, and I can't even afford to do the care because the deductibles are so outrageous. And when you're choosing insurance, you don't necessarily understand that they're telling you they don't necessarily list all the deductibles. You're going to pay for office visits. You're going to pay sometimes for specific diagnostic testing and things, and that's okay. But when you go and you get a diagnosis and they tell you this is what it's going to take to get us in a better place, and then then you find out that you have to pay this deductible before you can get the work done. So for me, and this has happened to me more than once, so it's very frustrating, when you feel like you've taken the right steps, you've done the right precautions, but at the end of the day, you still cannot do the things necessary and needed to have the ultimate for yourself health-wise.
Thank you, Ms. Goins. Are you done with your testimony today?
I believe so. Thank you for the time.
Thank you for being a part of the process here today. If next we can go to Ms. Duncan, I see her on my screen next, so that's why I'm going there. Go ahead and unmute and make sure you state your name for the record.
Hi, greetings everyone, greetings sharing committee. My name is Asia Duncan. I'm a small business owner, and today I come before you because simply it's difficult to pay for health insurance, not just for myself as an individual, but even small group healthcare plan options for my team are expensive and unsustainable for my business at this time. Healthcare accessibility and affordable healthcare coverage, in my opinion, is essential to individuals and families' overall health and wellness. I care about the individuals who work for me. I care about their families, and I would love to be able to provide healthcare options available to them, but I don't want it to affect, my business's ability to profit. The average annual premiums for small group health plans were roughly $3,500 to $5,000. On top of several other necessary and mandatory insurance coverages that I have to have, it just wasn't a feasible option for us to also add healthcare in addition. Individually, my premium is around $4,001 a year. And I went to, the marketplace and shopped around and did, and tried to find the best policy and coverage for me and my family, but I'm still paying $4,000 a year. Health insurance for me is just one of those, in the event of an emergency situations, because I feel like I practice healthy lifestyle, healthy living. But I do know some people that work for me, they have pre-existing conditions and other life-altering illnesses. And when I talk to them about healthcare, they often tell me that what I pay them, if I pay them too much, then they won't qualify for their Medicaid. So I don't really understand all the time, how Medicaid relates to pay raises. I always thought it was a good thing to get pay raise, but some of them don't want pay raises just because they need to maintain their Medicaid. So I hope my testimony today will allow legislators to considering lower the cost of healthcare overall for small groups and small healthcare plans, and also for individuals and people like myself. So thank you.
Thank you. And I think we have one other testifier, Assemblyman Orenlicker. What was that individual's name? Maybe you can ask them to unmute if they are on here.
Is Casey Kristen. Not sure if he was able to make it, but that's Casey.
Yes, I'm here. Can you hear?
Great.
There you are. Go ahead and make sure you state your name for the record and begin your testimony.
I am KC Christon, Christon. One of the things that I would like to, first of all, good afternoon, everyone, and appreciate the invitation. But one of the things, I don't necessarily want to talk about myself. I would like to talk about the families that I serve. I work for Acelera Learning, the Head Start program. And if you all are familiar with that, we serve the 6 weeks to pre-K. We deal with a lot of families, diverse backgrounds. And one of the things that I am seeing, or the pattern that I'm seeing, is the challenge for these parents to have and obtain health care. When they do have health care, the system is quite challenging to navigate. So if a simplified way of providing health care is available, that would really be beneficial to members of the community. It's a lot of reading and the terminology. A lot of folks just are having a challenging time understanding what it means and to interpret what it means. And also, what happens if they do this? What happens if they do not do this? They come to me, I'm their first stop. Like I said, I work with their children at the school. So I get a lot of questions, and I find myself doing a lot of research just to answer basic questions for the parents. I can understand their frustration because there was some time that I didn't have health insurance myself. So being able to navigate the Medicaid, Medicare system in Nevada is challenging. And so I can only imagine what these parents are going through on a daily, weekly, monthly basis with multiple children, some who have moderate health problems, some who have severe health problems. So that's one of the things that I would like to present to you all today. And if that could be considered, I'm sure that would be greatly appreciated.
Thank you for being a part of this presentation, and I will turn this back over to Assemblyman Ohrenlicker for any remarks prior to opening up for questions.
Thank you, Chair. We can go to questions now, thanks.
Sounds good. We have quite a few people in the queue, and I'm sure it will spark a conversation where other people will light up. So if you members of the Health and Human Services Committee, if you can go ahead and send your questions to me. I will direct the questions to Assemblyman Ohrenlicker first, so we're not doing this round robin kind of where everyone has an answer for the question, and maybe he can direct who would be the more appropriate person to answer that question. So at this time, I will start with Assemblyman Hafen.
Thank you, Madam Chair, and thank you, Assemblyman Ohrenlicker, not just for presenting today, but for the number of stakeholder meetings that you had. I participated in the working group with you, and I know it's been difficult working in this virtual world with such a complex bill, but I do think that your passion to try to bring healthcare to all parts of our state is something that we all agree upon, and so I just wanted to. I know there's a lot of moving parts in the building with other bills, and I know you've co-sponsored a few other bills to try to help address some of the healthcare issues of bringing medical professionals to the state. And my question is that, has there been any consideration of what is going to happen with the doctor shortage that we currently have in relation to how this bill would be implemented? Would we see an increase or would we see a decrease? And would this be seen to be an attractive measure to bring additional medical professionals to the state? Thank you.
Thank you, David Ohrenlicker, for the record, Assembly District 20. Yeah, I think this will do a lot to make Nevada more attractive. The low payment on the Medicaid side is a perennial and serious irritant to physicians and other providers that we don't pay them adequately, they lose money. And I think being able to say we pay at Medicare rates for Medicaid would be a huge benefit and make this much more attractive. Not having to deal with multiple insurers and all these negotiations and having to have the number of billing clerks and other administrative staff that increases the cost of running a medical practice. Being able to bring primary care reimbursement up so that, as I said before, right now, if you're a pediatrician or an internist or family doctor, it's very hard now to make a go of it on your own. And we end up seeing more and more doctors selling their, becoming employed by hospitals or private equity firms. And it's much better if they can retain the option of maintaining their independent practice. It's better for their patients. So I think there are a lot of benefits, and having a freeze on the non-economic damages cap, doctors will love that when they're thinking about where to practice. So I think this will go a long way to address the doctor shortage.
Thank you, Assemblyman Hornlicker, and thank you, Madam Chair.
Do you have any follow-up questions, Assemblyman Hafen?
I have some additional questions, but I think I'll let other members ask their questions and come back. Thank
If
you.
we can go to Assemblyman Matthews.
Thank you, Chair Wynn. Thank you, Assemblyman Hornlicker. And I want to echo what Assemblyman Hafen said about your efforts in working this bill. And I know you reached out to me individually. I appreciated the opportunity to get together with you and talk about it. Obviously, you covered a lot of ground there, and I know you may have touched on some of this peripherally at least, but I'm hoping we can kind of zero in a bit more. Talk a lot about obviously the issue of rates and the rate setting, and I'm wondering if you could speak to under this bill who exactly would set these rates, and how do we ensure that a commission will be educated and informed enough to intelligently evaluate and consider all the relevant market variables here, and not be conflicted by outside influences in that process. Thank you.
Thank you, Assemblyman, and David Hornlicker for the record. That's a good question. And the way we're conceiving of the commission now is that it would have a board with a wide range of stakeholders to make sure all voices are represented, and that insurers, providers, employers, workers, patients, all are there to make sure the commission takes into all their views are taken into account. But it also will have a body, a staff of expert analysts who can look at the data and figure out, as Medicare does now, what are fair costs and what's a fair profit. We've seen, and as Professor White indicated, every other country has been able to do this. We do it with public utilities, a similar model. So we do have to properly staff it and properly, both the people who do the data crunching and the people who are on the board. But there are good models out there, and I'm certainly willing to make, I'm very interested in feedback on how we can design it as well as possible. And perhaps Professor White might, if you're anything you want to add, please do.
One thing is there's an issue of how you think about what outside influences are, because the really important outside influences are the people who are asking for more money, right? And they're going to try very hard to influence to get more money. I'm not sure there are other outside influences that are going to be playing on these kinds of things. If you look at the questions of sort of underlying costs, a lot of this stuff, like geographic variations in rent and labor costs and so on, are actually already in the Medicare formulas for hospitals. If you're thinking, and I think that as a general approach, it makes sense to say, here's a standard that, by the way, I think the Medicare rates will be the Medicare rates, once costs go down for providers due to lower administrative costs, will be even closer or more certainly adequate. But I think that, you do need to have some sort of process of appeals and making a claim that we're different for some reason. And that would probably work the same way any other appeals process in a body works. I think that we can't be sure it'll be perfect, but I think it should be pretty good. I also think we can be absolutely sure that the providers who have the market power to, depending on your word, achieve or extort higher prices will say it's unfair. I mean, we know that will happen for certain.
Thank you. Follow up, Madam Chair?
Go ahead, Assemblyman Matthews.
Thank you. Someone, thank you for the response. Professor White, you as well. Reference experts. An expert in one field, obviously isn't necessarily an expert in another. So I'm wondering, what you have in mind. We talking healthcare professionals, providers, economists, academics, combination of those, and what would happen if, experts won't always necessarily agree, and they may end up having, based on their areas of expertise, sometimes those things can come into conflict. So I'm wondering how you might see that playing out and what field or fields these experts may be drawn from. Thank you.
Well, personally, I would like accountants. I think there's going to be a claim made that our costs are higher for some reason, and I would like to see people who can assess the data used to make those claims. I think that there's an argument for having a variety of skills on these panels, and I think Assemblyman Orndlicker has thought more about that than I have. But I think what you want is a variety of skills, a variety of perspectives. But I do think that one substantial part of it is just accounting. Somebody is making a claim about costs, and are they telling you the truth? Are they actually not understanding their own costs, and the costs are actually higher than they're saying? So I actually think that's probably the most fundamental, skill set here.
Thank you. Madam Chair, could I ask one more question?
Yes, that would be fine.
Thank you. Again, it's sort of a multiple part question. Assemblyman, wouldn't a cost-based rate system sort of incentivize increased costs if it's structured that way? And also, how exactly are we defining costs, and who would be defining what those costs are under this bill? Thank you.
Yeah, that is one of the risks, that people will try to inflate costs. So that's one of the advantages of starting with Medicare, because Medicare does a lot of vetting already in terms of what are reasonable costs and what are not reasonable costs. And then we will have the staff, the expert staff, the accountants and the economists and the people, the health policy people who can then, the burden will be on the providers to show that this cost is a reasonable cost. It's not to cover all costs, it's to cover reasonable costs. And they will have to justify and prove that this cost that Medicare, say, doesn't cover actually is a reasonable cost. And the other thing that's part of the rate setting is to reward efficiency. That, some providers, we know some hospitals are more efficient than others, and the rate setting commission will take that into account, because they'll see what other, they're not going to look at just one, they'll be looking at the full range of providers. So they'll have a good sense of who are the efficient ones and who are the inefficient ones, and that's something they'll take into account. So the important thing is Medicare is already doing this and has been doing it for a long time. And so we know it can be done in a pretty effective way.
All right. Thank you, Assemblyman. Thank you, Professor White. And thank you, Madam Chair.
I have a question for you, Assemblyman Ornlicker. I saw in the amendment you have a cap on non-economic med mal damages if the provider group participates in the provider tax. Can you kind of give me some reasoning behind that? I know in your presentation, like in chief, you had indicated that those medical malpractice claims like account for less than 1% of like the cost. Was that as a part of conversations with stakeholders? How did that come about, that amendment?
Good question. Thank you, Chair, Assemblyman David Ornlicker, for the record. Change can be scary to people, even if it's the right thing to do. When you're proposing a significant change, people get nervous. And so to provide reassurance that we are trying to do the right thing and to make this a more appealing opportunity for providers as they're trying to decide whether to vote for this provider tax, that adding in the protection on the medical malpractice, which is something that causes a lot of anxiety for them, is where anything we can do to assure them that this is the right thing to do for them, that they will be better off, that their patients will be better off. If anything we can do to provide reassurance, I think will be helpful.
And then just a follow up on that data that you had presented during your thing, that those medical malpractice claims only represent like such a small percentage. Where did you get that information? Is that in our state? Is that nationally? Where is that kind of 1% number come from?
That's pretty widely accepted national data. I can provide a particular source if you'd like, but that's the standard view of what the total costs of the tort system are. People will say, well, what about defensive medicine? And that doesn't include defensive medicine, and that's harder to pin down. You can measure how much is spent on liability insurance and court cases. So that 1% is a pretty good number. The defensive medicine, that's in the minds of doctors. But estimates there may go as, maybe 3 or 4%. Some might go to 5%. But a lot of it is, as I say, to provide, even if it doesn't cost you dollars to go to court, there's a lot of psychological cost to having to defend yourself in a lawsuit. And so that doesn't show up in the 1% of economic costs.
Thank you, Assemblyman Ornlicker. I have some questions here next I'll go to Assemblywoman Peters.
Thank you, Chair. And thank you for bringing the bill. Additionally, would like to reflect the sentiment of my colleagues that the work you've put into this has been really impressive. I know I've been invited to a number of meetings, had conflicts for most of them, but sat in on a little bit of it. I wanted to ask a little bit about the data collection that was referenced, which would be used to determine the payment amounts, right? Can you talk a little bit about what is currently being collected, how we would have to modify that collection practice, where it would be hosted, that data collection? And then also, I have a follow-up question, but I'm going to start with that piece.
Yeah, sure. Thank you for that question, Vice Chair Peters. David Ornlicker, for the record. One of the advantages of structuring it the way the bill does, to say start with Medicare. So hospitals are already filing, for example, Medicare cost reports. So they've already accumulated a lot of data to start with. And then the second part is, if providers think that Medicare is not adequate, then they have the opportunity to come before the commission and say, we need to raise the rate by 5%, 10%, whatever they think is right. They might say 40%. And then they have the obligation to provide evidence, the data, to support their claim. So the data will come to the commission through the petition process, because you can't demonstrate that you need an increase in rates unless you show us your cost data. So it will be inevitably follow from the process.
So I'm totally a data nerd, and love technology, databases, data management. And I was like having this this fantasy of a process in which we could use like an artificial intelligence to run an algorithm on data input by these entities and really leave like the experts and people out of it after we've just like oriented a process that was amicable. Anyways, a little sci-fi like for us in committee here. My other question has to do with like, again, some of the data you presented related to the difference in costs between medical procedures in the United States versus other countries. And I wanted to ask about whether those accounted for the difference in cost of living expenses in the United States. As we know, particularly compared to Taiwan, that living here costs a little different than living in Taiwan. So can you just explain a little bit about how that is normalized?
Yeah, thank you, Vice Chair Peters, David Orentlicker for the record. And after I finish, Professor White, please add if you have more. I don't know about the cost of living in Taiwan. So I was planning to use Japan. I just was having trouble getting the numbers from Japan. Japan has a much higher cost of living, and their prices would not look that different from Taiwan. So the cost of living doesn't explain the difference. The major difference is governments negotiate. When you have a single negotiator on the payer side, on the buyer side, the purchaser side, the government, that's just how government negotiating is just a lot more leverage than we think of insurers as be big and bad and powerful, but compared to a government, they just don't have the same kind of negotiating leverage. And in a lot of communities, hospitals do. If you're the only hospital in the community, or if you're a Cleveland Clinic or a MD Anderson, a must-have clinic hospital that patients want to have in their network, then they've got a lot of negotiating leverage. And when the government is negotiating on behalf of all patients, you get a different result. And that's why you see the lower prices. It's to say Japan has a much higher cost of living than we do, and their prices look a lot like Taiwan.
If I may?
Go ahead, Mr. White. Make sure you state your name for the record.
So this is Joseph White for the record. So a couple of things about this. One is that there are even situations where it's not the government that sets the prices. In Germany, the insurers get together and the system sets it up so that they get together and negotiate as a side with the providers as a side. But that has the same effect. What you are doing is you're concentrating the market power among the insurers. So that's in a way that doesn't exist in the United States. American insurers, in spite of the fact that people complain about them all the time, the really striking thing about American insurers is they are wimps. They are very bad at negotiating prices, and that's partly because they have a choice. They're actually a middleman. And on one side, they are negotiating with individual employers who are very small compared to them normally. And on the other hand, they're negotiating largely with concentrated hospital networks and with, in many communities, it's like 3 cardiac care groups, really. And so they have to make a choice. Do they negotiate harder with the people with whom they have less market power? In other words, with the providers, or with their customers? And the answer is that it is easier for them to pass the providers' demands on to their customers. And what their market power means is that there's not that many insurers, so there's not many places for the customers to go. But our insurers are weak. Now, on the on the question of comparing costs, yes, you cannot simply use exchange rates, and say, well, we'll turn the Japanese yen into dollars at the current exchange rate and make the comparison. That's somewhat indicative. But the fact is that there's only so much it gets you to. And so there are a lot of analyses that have gone into greater depth and done things. One of the things is simply just to show the big difference in percentage of GDP, because gross domestic product includes, basically includes, everything in the economy. So if we're at 18% and somebody else is at 12% or 11%, then we really must be doing something more expensive. And if you look at what we're doing, it's prices, okay, not volume. And some of that, by the way, is for drugs. And this doesn't really address drugs, okay, which is a different issue, okay, different problem, but a major one. But the other side of it is there have been people who have tried to control for local costs of living and so on. In particular, back in 2007 and 2008, McKinsey, that good left-wing organization, McKinsey, did a really detailed study. And with their adaptation and their estimates were based on controlling for underlying cost of living differences to at least some extent. And they still found the same basic story, which is that the difference in cost between the United States and other countries is due to prices and administrative costs. Having said that, it's important to understand what spending less would mean. On the one hand, probably on average, not in every country, for instance, not necessarily for non-hospital doctors in Japan, American doctors are paid more. And the question is, if you care about doctors, whether the fact that they will have significantly lower costs because they won't be paying all these administrative staff means that you can pay them lower fees, but still they'll end up ahead, or at least equal. The second thing you have to remember is that if we're saying there's a lot of unnecessary billing work, then I have to admit, we are saying there are some jobs that will have to go away. Because if you have those 2,000 billing clerks at the Cleveland Clinic and you simplify, then there are job losses. And then when you're doing your calculation of whether a hospital needs more money, if the CEO is making $3 million, then maybe you don't want to accommodate that in the claim for more money. So there are potential losers. On the other hand, the winners is potentially everybody else. Again, what we're talking about is a situation in which even people with good insurance are losing it. The big beneficiaries of the non-Medicaid part of this plan, right? Medicaid is improved by paying higher rates, so people with Medicaid can get better services. But the big beneficiaries are the people who have insurance through their employer, which will be insurance as costs go down will be much more affordable for the employers. The employers will have less need to cut benefits the way they have been doing. What is going on right now is the increase in costs in the system has its biggest effects on people who are getting insurance through their employer. Most of the people who are getting it through Medicare, well, Medicare's prices are regulated. The people who are getting it through Medicaid, different problem. The people who are getting it through the marketplaces, their premiums, if you're under 400% of the federal poverty level, are limited anyway, limited already. So the big winners from controlling healthcare costs in the system as a whole more effectively are employers, including the state of Nevada.
Thank you for breaking that down a little more. I think, in response, calling someone a loser for reducing their annual pay from $2 million to something less does not seem like that big of a loss to me compared to someone not having to be buried for the rest of their life for a hospital bill because their child fell off their bike. So, you know, the cost and benefits balance has to have some perspective, I think. But thank you for those responses.
Thank you.
I
Next
mean,
time we'll go to, just in the abundance of time, I'm going to keep moving along here. I'm going to go next to Assemblywoman Krasner.
Thank you, Chair Wynn, and thank you, Assemblyman Orentlicker, for your very interesting presentation. So my question is, let's say somebody breaks their arm and they need to go to an orthopedic surgeon. Would an orthopedic surgeon who's skilled and been doing surgeries on broken arms for 20 years get paid the same as an orthopedic surgeon who's been just doing surgeries for maybe 6 months?
So David Orentlicker, Assembly District 20 for the record. Will we have different rates for different providers? Potentially. It would, if the bill does include a provision to say quality of care should be taken into account. That, I think it's a good idea. That said, quality-based payments do not have a very good track record. It's a very good concept in theory, but in practice, we've found that it's been very difficult to, you know, adjust reimbursement based on quality of care. It's been tried for a long time. And as I say, that the evidence is not very good for its effectiveness. And but that said, as I say, the bill does include it, and it would be if a provider could demonstrate that they're providing higher quality of care, that should be rewarded.
Okay. And
I just want to add, Professor Wright did say we may lose some billing clerks, but other employers who have lower healthcare costs will be able to hire more workers. So I think overall, we're more likely to get more people working when you lower healthcare costs. If you lower the cost of operating a business, you're going to expand your business more quickly and hire more workers.
Okay.
Go ahead with your follow-up, Assemblywoman Krasner.
Thank you very much. Thank you, Assemblyman Orentlicker. So would there be a way for a provider, a doctor, or a hospital to appeal the rate that was found to be applicable to that provider or that hospital?
Assemblyman David Orentlicker, for the record, yes, they would. So initially they would come in and say, we think we should have a higher rate. They would get a response from the commission, and there would be an appeals process within the commission, as there is within Medicare, to challenge and say, we want you to reconsider this.
Thank you.
Do you have any other questions, Assemblywoman Krasner? No. I'm next going to go to Assemblywoman Titus, who I'm sure has one question or a couple. Go ahead, please ask your question.
Thank you, Madam Chair. I do appreciate the opportunity to ask some questions. First, I want to thank Assemblyman Orentlicker for the presentation, for the time and effort that he's put into this bill, and that this discussion is really a nationwide discussion that has been going on for decades, and to solve the nationwide problem in a couple-hour testimony is a heavy lift for anybody. But I do believe that these are conversations well worth having. So I do appreciate it and all the time you put into it. I'd actually like to go to the bill itself and ask some questions pertaining to the actual bill, as opposed to conceptually healthcare and its issues in our nation and worldwide, actually. And so with that, the amendment that you added, and it plays along with some of what Chair Wynn asked regarding on section 6, sorry, in your conceptual amendment about the provider, if they choose to join this, then they're going to be capped on the economic damages. And I'm curious about opening up that particular chapter in NRS, and what will happen to those providers who don't sign on. They're going to have now unlimited exposure. Can you clarify that for me?
Yeah, so the way, just to be clear, the way the Assemblywoman David Orentlicker, for the record, the way that the provider tax has to work under Medicaid rules, if you come in and if you apply it to a class of providers, hospitals are a class, physicians are a class, dentists are a class. So you are allowed to further, you could subdivide physicians and say, we only want pediatricians to come in or emergency doctors to come in. There are paths to do that, but it's very difficult to do it that way. So let's assume all doctors come in as a class. That happens only if 2/3 of doctors in the state vote to, assume the tax. Then Medicaid requires that everybody's in. So if you voted against, if you're one of the 30% that voted against it, you still pay the tax.
Wait, was about this economic damage on your amendment, and it's in blue and it's number 5, and it talks about the non-economic damages shall not be raised and applies to provider. So that's on all providers in that group. But what about those who haven't joined or in a group, and those who, like me, that was in private practice at one point in my career? So we would be protected underneath that.
David Orntlicker, Assembly District 20 for the record. If physicians as a class choose the provider tax, then every physician in the state will get the protection of the freeze on the non-economic damages cap.
Okay, thank you. I'm not still, we'll move on because I have so many and I want to get hung up on that. At this point in time, how, under that same section, your amendment under section 6, number 1, you're providing that the future legislators declares that we will not raise the maximum amount of non-economic damage. How can you commit a future legislative body to that? How can you put that in a statement? Because we can't we cannot, we don't know what the next group makeup will be of this body. We can't commit the future legislative body to what our decisions are today. We can pass NRS, but they can be free to change it. So I'm worried that that kind of commits us to prevent future legislation. Could you clarify that?
Yeah, David Orntlicker, Assembly District 20 for the record. You are correct. As a matter of legislative and constitutional principle, we cannot bind future legislatures. That said, this would say to future legislatures, we passed this bill that had many parts. It is an integrated whole. If you start picking out one part, it's like unraveling a sweater when you start pulling on the threads. And so that would be an inappropriate thing to do. And just to make sure that you think twice about trying to do something like that, that if you do that, then the subsection 6 of the amendment talks about how the HHS will have entered into a contract with the provider group as part of the process of imposing the provider tax, that if a future legislature raises that non-economic damages cap, then that will mean that will cancel the provider tax. So that future legislature would have to recognize that if they raise the non-economic damages cap, they will have to start sending back tens of millions of dollars to the federal government. They will have to cut reimbursement rates to Medicaid, to providers who take care of Medicaid recipients, and they will have to compromise access for Medicaid recipients, compromise access to care. I think that's a price a future legislature will not want to pay.
Madam Chair, additional question?
Of course, and I will remind members, we will have another opportunity to ask questions, but go ahead.
Thank you. So at this point in time, having lived in the real world of an office practice, also in private practice, and then again working for the hospital district, I know that Medicare does not reimburse at cost now. They don't, and it's difficult getting doctors to see Medicare patients. Obviously, your concerns about, it's even worse getting doctors to see Medicaid patients because they pay at a lower rate. Right now in Nevada, Medicaid pays 95% of the Medicare rate. That's pretty much general what their reimbursement is. At least that was until during special session when we lowered an additional 6% on Medicaid reimbursement. But it looks like we're going to go back up on that. So let's say Medicaid pays 95% of what Medicare pays. And we know Medicare doesn't pay for our cost of doing business. How I would see whoever walked through my door. The issue wasn't me seeing them. The issue was me getting them referred then to a provider who would, heaven forbid, see a Medicaid patient, but I could not get them to see a Medicare patient. So I am concerned that then setting these rates, and we're talking about, where the private insurers are going to go. You're obligating private insurance companies too, not just Medicaid, Medicare, but we're talking about a global price control here that you're going to obligate private insurers to, and then how will that encourage anybody to practice healthcare in Nevada? So I have huge concerns that this is going to, although your intention is to have them see more patients, I think you're going to do absolutely the complete opposite based on what this bill presents today. So I'm anxious to hear some more discussion on it, but I'm really concerned about price setting and how that will actually impact me as a provider, getting that person who I couldn't get seen for Medicare now, let alone get them to see Medicare in the future. So I guess that was more of a box, standing on a soapbox more than a question. But again, I'm just not seeing how. I guess I could ask this question: How will this may affect Medicare rates and people who see Medicaid and Medicare, but those who don't see these patients, those who don't see Medicaid and Medicare, is this going to force them to accept these same rates down? And if so, does the federal government, will there need to be changes on a federal government regulation standpoint?
David Orntlicker, Assembly District 20 for the record. I'm confident that if doctors are promised that they will be paid fair reimbursement for all of their patients, and perhaps with Medicaid, not quite all the way, but pretty close, and that for all that overall they will receive fair reimbursement, and they won't have the hassle of dealing with negotiations with insurance companies, and they'll have extra protection against liability for malpractice. I think that's a pretty good deal. And I think I'm not worried about the appeal of that to doctors around the country. For the doctors who want to earn excessive reimbursement and more than a fair income. So I think we'll lose some people like that. I think from what I know about doctors and from what I know from myself as a doctor, that there are going to be more doctors who will be attracted to Nevada than will want to, earn excessive reimbursement. And maybe that's not good for patients, having doctors like that who care that much about how much they earn, that a fair profit is not adequate. Because if they're not happy about earning excessive profits, that makes me worry about how they deal with their patients.
Final question, Madam Chair, I promise. So with this commission determine an arbitrary of what they will decide is a fair reimbursement. Now, this commission does, not the provider, based on cost, et cetera. This commission does. Will the commission take into consideration research, development, advancing, or being able to grow a practice? Or do you know if that commission, is it anywhere in this bill? Because I couldn't see it. If that commission is going to allow for a reasonable profit margin so that then you can reimburse in some of the just, building a bigger practice, getting new equipment, getting modernization, those costs of doing business that every other business has to look at. Will that be a factor considered? Because I don't see it in the bill.
David Orntlicker, Assembly District 20 for the record. So that sounds like something that would be part of the concept of a reasonable profit. That's one of the reasons to have a profit, is so that you can invest in expansion for the future. But it's certainly something we could put in to make sure it's clear.
Thank you, Madam Chair, for your patience. Thank you, Assemblyman Orntlicker, for answering the questions.
Thank you. And at this time, I'm actually going to go to the phone lines to start testimony in support of Assembly Bill. Well, I've lost the number again. 1 second. Assembly Bill 347. Thank you. So Assembly Bill 347, broadcast services. I would remind callers to please clearly state and spell your name for the record, and please limit your testimony to 2 minutes. And with that, we'll go ahead and begin.
To testify in support of Assembly Bill 347, please press *9 now to take your place in the queue. The caller with the last 3 digits, 904, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, my name is Alex Camberos for the record, ALEXCAM as in Mary, B as in boy, ER as in Romeo, OS. And I'd like to speak in support of AB 347. To share a little bit about my health history, you know, I used to have Medicaid. It saved my life. I was able to see doctors and specialists who could help diagnose my critical chronic illnesses. And eventually I had to find my own insurance. I did my research. I found what was available for me, what was covered by my doctors. And even then, I still struggled to pay my premiums, my co-pays. And I think it's a struggle that a lot of my friends who also share various ailments experience in Nevada. There's not enough folks who want to accept Medicaid because the reimbursement rate is too low, and they can't always see a doctor because they can't afford to, even with insurance. I think what the bill proposes, brought forth by Assemblyman Orntlicker, is a good step in the right direction to further provide affordable health care for Nevadans. So I urge this committee to support this bill, and thank you.
Thank you. If we can go to our next caller in support.
The caller with the last 3 digits, 960, please slowly state and spell your name for the record. You have 2 minutes and may begin. Caller with the last 3 digits, 960, please press *6 to unmute yourself.
Hello, my name is Robert Gullickson, Gullickson. Thank you, Madam Chair and committee members. I'm here to voice support for Assembly Bill 347 to help ensure that healthcare reimbursements are fair for both patients and providers. I want to clarify that today I'm speaking on behalf of myself and not on behalf of the University of Nevada School of Medicine or the United States Air Force. As a second-year medical student, I've had the privilege to volunteer both in Southern Nevada and up here in Northern Nevada in clinics aimed to help underserved populations. A lot of times these patients are not seen due to lack of providers who accept Medicaid. And as a result, a lot of them slip through the cracks in our healthcare system. It is my belief that this bill will improve access to healthcare for Medicaid patients and subsequently reduce the incidence of many preventable diseases that Nevadans are faced with. I'll just kind of end on commenting on the fact that I do believe that this bill will help address the physician shortage here in Nevada by providing fair compensation to physicians. Thank you.
Thank you. If we can go to our next caller in support.
The caller with the last 3 digits, 927. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, my name is Hava Ahmed, Hawh, AHMAD, and I'm here representing the Clark County Education Association. So today we want to thank the Assemblymen for bringing this bill forward, and we're in support of it because it's a very much needed conversation that we have to have. Given that we're in the midst of a pandemic, we know that we are about to foresee some more social, emotional, and learning issues that we're going to have to address in addition to our health issues. If we don't start this conversation now, then we're going to be hurting down the road. We look forward to seeing this bill progress and to really figuring out how we can come together in a bipartisan fashion to address the healthcare needs of every Nevadan. Thank you so much and have a wonderful day.
Caller with the last three digits, 755. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair and members of the committee. My name is Marlene Lockard, Lockard, representing SEIU 1107. We appreciate the opportunity to work with Assemblyman Ornlichter in his working groups to make this the best bill that could possibly be made, and appreciate the opportunity to provide input. As part of this effort, it is imperative to acknowledge the heroic efforts undertaken by the healthcare workforce during the pandemic. As efforts to vaccinate and control the pandemic continue, it has become clear that the workforce is exhausted and solutions are required. Healthcare workers have always been on the front lines of caring for our communities, but under the microscope of the pandemic, the industry and rest of society are clearly witness to their dedication, bravery, and stress. We are in a time of crisis, and healthcare workers are stepping up across the country and in Nevada to save lives, sacrifice their own health, and work to save the health of our communities. Again, we appreciate the the opportunity to have input, and we thank the Assemblyman. Thank you very much.
Thank you. If we can go to our next caller in support.
If you have recently joined the call and would like to testify in support of Assembly Bill 347, please press *9 now to take your place in the queue. Chair, we have no callers in support at this time.
Thank you. At this time, I will begin testimony in opposition of Assembly Bill 347. I do have, I believe, I'm counting 1, 2, 3, 4 people that are on the Zoom. Like I had said at the beginning of this meeting, I do plan on giving them a little bit of additional time just because I know that there is pretty complex nature of this bill. And I know that the stakeholders kind of represent some key industry players that are a part of this conversation. So I guess I will start. I don't know if they have a particular order. I would remind them to, again, state their name and limit their testimony to the 4 to 5 minutes that we had talked about before. Again, I would ask them to stay on the line so they can be a part of any further questions that we might have after opposition testimony. So with that, I will start probably, it looks like the first person that unmuted and turned on his camera was Jared Hildebrand. So why don't you go ahead and go first.
Thank you, Madam Chair, and I appreciate the opportunity to be on the Zoom and give some provided remarks with our respect to our opposition. And firstly, I'd like to thank Assemblyman Ornlichter for meeting with us and going over our, his proposed amendment and bill. And unfortunately, we just can't get there. So my name is Jared Hildebrand, and I'm here on behalf of the Nevada State Medical Association in opposition for many reasons, but specifically, I'd like to start with the provider tax piece. Firstly, we're troubled by the fact that provider taxes would not be borne equally across the healthcare providers. There are many provider types within Medicaid system that don't deliver care, or that do deliver care to patients that don't receive the benefit or that receive the reimbursements. It's fundamentally unfair to select providers, skilled nursing hospitals, and physicians to be focused on the tax to bear the burden, while other Medicaid providers, home health agencies, personal care, et cetera, hospice, behavioral health, are all folks that receive or participate within the Medicaid system that are exempt. Right now, there's only one state in the entire nation that has physician-specific provider taxes. That state is Minnesota, and they are currently being phased out at the moment. I also would like to touch on that there are certain requirements that we need to implement for the tax to actually work. Like the Assemblyman alluded to, 60% of my providers in the state would need to participate. Our provider groups are not homogeneous. We have a myriad of specialties, and then within those specialties, we have subspecialties. Many of those specialties do not feed a fair amount of Medicaid beneficiaries. And then we do have some that would make sense. For example, if we would take a pediatrician, for example, in Clark County, and this is a hypothetical scenario. Some of these specialties, like a pediatrician and a subspecialty within that, their practices see up to 60+% of Medicaid beneficiaries. Plus, then you get into some of the other 10%, and then really about 20% is the commercial payers. And we need that 20% to absorb those costs, because those Medicaid reimbursements, we're losing 40 cents on the dollar every time we see some of those folks, just based on the lack of reimbursement. So, like I said, there's CMS requirements that need to be implemented. The nationally approved provider tax implemented on skilled nursing would make sense because it benefits their business model. They have a set population group that they serve, and it makes sense for a skilled nursing facility to implement provider taxes to get a higher reimbursement rate on Medicaid. CMS must approve these taxes on 3 conditions. Taxes must be broad-based, imposed on all providers. Taxes must be uniform, imposed both on Medicaid and non-Medicaid providers. States must not hold providers harmless for the burden of the taxes. However, there is a safe harbor clause. Providers cannot exceed 6% of their revenues, either they're putting into the tax or receiving the tax. Right now, with respect to the holistic piece of the bill, the Peterson-Milbank and the PPC have picked Nevada as one of the 5 states to study this exact bill, to study the sustainable healthcare costs. So one, we would prefer to see this more. Let's see how the PPC, how we look at it in the PPC, and get some hard data on this. And then I also would like to touch on that, within the I guess rate fixing piece, we feel, yes, we can appreciate the fact that the Assemblyman would like to increase the Medicaid reimbursement rates, because it's a major need for Nevada. However, we don't think that the provider tax is the right mechanism, just due to the fact that I don't think within our physician community, and like I said, how the various specialties, that we could get to a 60% I guess threshold to trigger those provider taxes for those reimbursement rates. And on the same token, with the MedMal, the Chapter 40 piece, and hitting that, I just don't know if that's the right mechanism there for a MedMal cap or for discussion on that piece. I also would like to discuss, there was a document that came out regarding in 2018 with respect to provider taxes and the division of the division of DHC, DFP. It states that the estimated aligning Medicaid rates with the current 2018 would require an additional general fund appropriation of almost $86 million. That was fiscal year 2018, and then an additional $88 million for fiscal year 2019. So that was over close to $175 million just for those 2 years. Now this is a new biennium that perhaps could be the cost could be even further burdened to the state. And then I also wanted to bring up that this is specific to fee-for-service. $175 million is specific to the fee-for-service rates. We still have 72% of all of our Medicaid beneficiaries that run through MCOs, and those are all contractual based with physicians in our healthcare system. It's completely separate from the fee-for-service. So I have no idea how you would provide a provider tax on a provider when they're running everything through an MCO and they have a contract with those particular MCOs. So those are some questions I do have. And I do believe with the rate piece, I think it would do the opposite. In fact, that physicians would not. I think it would be a deterrent for folks to get here. And I just want to touch on how significant our provider shortage is. Just alone, family medicine in the state of Nevada, just to get to the national average, we would need an additional 288 providers. In internal medicine alone, just like I said, just to get to the national average in the state, we would need an additional 211 physicians. Pediatric physicians, an additional 244 physicians. General surgery, 123 additional surgeons. OB and gynecology, an additional 111 physicians that we would need to bring to the state. And if they don't have those commercial rates, those higher reimbursements, and I do, again, appreciate the Assemblyman for trying to increase the Medicaid rates to a Medicare rate level, but we still feel that is unsustainable for our small businesses and our small practices in our state to sustain. And we worry that would just be the end, essentially, of private practice, and folks would just become employed physicians. And that's some of our biggest concerns with this bill.
Thank you for providing that testimony, Mr. Hildebrand. If we can go next to our next person in opposition, and I'm looking at this, I will go next to, how about Mr. Tom Clark?
Thank you, Madam Chair, members of the committee. My name is Tom Clark. I represent the Nevada Association of Health Plans. We are the private insurance carriers here in the state. We make up only 19% of the marketplace, and as far as the health insurance marketplace is concerned. And our opposition really comes down to the relationship that the health insurance providers have with providers. And the impacts of the rate setting commission and setting up those rates is going to send a ripple effect, much like Mr. Hildebrand said, throughout the entire market here in our state. It's important to note, Department of Health and Human Services, Division of Insurance, the private insurers, public and private, every aspect of healthcare has been trying to work on attracting doctors to Nevada. Our biggest concern isn't necessarily the reimbursement rate, although Medicaid reimbursement rates are well below what they need to be. It's geography, it's demographics. When we look at attracting these doctors, we recognize as private insurers that there's a difference between a provider in Elko or Genoa, Carson City, Reno, Las Vegas. Will the rate setting commission and will the rates be set at a rate that is taking in all of those variables? And I know Mr. Orlicker has kind of addressed that the commission may, but nothing in the bill specifically states that that they'll take those geographic and demographic concerns into account. For example, we need more African American, more Hispanic, more LGBTQ providers in Nevada. We fear that setting one rate could send that ripple effect throughout the marketplace and not only keep those doctors from wanting to practice here, but also retain the doctors that we do have. I also want to talk about the context of AB 347 and what's happening within the health system within Nevada and other pieces of legislation that are occurring currently. And I think probably one of the best examples I have is the All-Payer Claims Database. Now, the All-Payer Claims Database was Senate Bill 472 from the 2019 legislative session. It didn't pass. But the Governor's Patient Protection Commission picked up the ball. There were hearings within the Interim Health Committee. They produced legislation that would create the All-Payer Claims Database. And while we were opposed to it back in 2019, because of the time that was taken to really take a look at what the APCD could do and the infrastructure for doing it, we now support the legislation as it's amended and going forward. Now, it's also important to recognize that that's just the collection of the data. And that data is going to be used down the road to set policies like AB 347 contemplates. So if Senate Bill 40 is to pass, and Chair Carlton also has a bill that addresses the APCD, If they pass, we think that that's fantastic, because if those bills pass in a way that create the infrastructure for us to collect that data, we can really have a stronger policy conversation about the health system here in the state. I'll also add that the Patient Protection Commission recently took testimony on a rate benchmark study that they're going to move forward with. And that information that comes from that study could also provide integral information towards this plan. As I'm sitting here contemplating my testimony, the other thing that comes to mind is many of the bills that this committee has heard and that we're seeing throughout the legislature address telehealth. We're in new times. And so will the rate setting commission take into consideration those issues around telehealth and how a provider is reimbursed based on the mechanism by which they provide the care? So with those issues laid out, the other thing that I will mention that is if this particular piece of legislation does pass, we're very concerned about the effective date, because there is absolutely no way that we can stand up this type of system this year. Just for example, in the conversations that we've had on the all payer claims database, just to collect the data, that infrastructure could take up to 2 years to set that system in motion. So with that, Madam Chair, I will remain online for any questions that may come. But I want to thank Mr. Ornlicker for having the stakeholder meetings and the numerous one-on-one meetings that we had. And it is important for me to note that we did have this conversation with him and addressed our concerns on a one-on-one before we just jumped into committee. So thank you, Madam Chair.
Thank you for that testimony. If next we can go to, how about Mr. George Roth? Go ahead.
Madam Chair, if it's possible to defer to Jim Wadhams, let him go before me. Is that okay, or would you?
No, that works fine. Mr. Wadhams? Hi, it's good to see you. Go ahead when you're ready.
Thank you, Madam Chair, and I appreciate that. For the record, my name is Jim Wadhams. I am here today speaking on behalf of the Nevada Hospital Association. I want to thank George for deferring. Just a couple of points, and I want to start out, even though we're appearing in opposition, I want to start out on a very positive note. Dr. Ornlicker has put in time and thought, and frankly has identified a major problem in the state, and that is our constituents' access to Medicaid providers. The Medicaid reimbursement for hospitals averages about 57% of cost, which is substantially lower than even Medicare. The attractive opportunity to eliminate that deficit certainly would levelize a lot of the costs that have to be shared otherwise. The problem, I think, is that raising that money for Medicaid is truly a problem, and without that, you can't achieve even what has been perceived and represented as having been done in the state of Maryland, where they have both Medicare, Medicaid, and all of the providers under a common system. The way I read this bill, it would not include Medicaid, certainly would not include Medicare, and so it ends up probably institutionalizing the problem that Dr. Ornlicker clearly identified, and that is the cost shifting. So the real question, I think, is as to the rate setting commission itself, it seems to be roughly patterned after a Public Utilities Commission regulatory system. And it's easy to think about it in terms of what we see with Nevada Power, with Sierra Pacific, with NV Energy, or other utilities that are regulated that are truly monopolies. And they're monopolies because they're given a service territory and a franchise of service. And the question, I guess, is this really a competitive market? We don't have a single seller. We don't have an NV Energy in healthcare. There is a restricted entry. Certainly not. In fact, the problem is the reverse. There is no restriction on entry, and we can't develop that workforce that Jaron Hildebrand from the State Medical Society identified we are so short of. On the hospital side, we've had Elite Medical Center was a hospital developed in Southern Nevada just in the last couple of years. So there is no bar to entry at all. Is there a lack of innovation in the marketplace, which would be an indicator of a monopoly? And that clearly is not the case. We have NICUs, we have burn units, we have trauma centers, we have stroke centers, we have a wide array of services, and the technology is here. I think the comment that was made by an earlier speaker is really worth mentioning. And this last approximately 13 months has been an extraordinary challenge for the healthcare system. And I think it's fair to say that the healthcare system has been stretched like a rubber band. The institutional capacity was identified early on by Governor Sisolak as something that we had to protect and make sure that we did not get overrun. The personnel that actually staff those hospitals, from the physicians to the nurses to frankly everybody that keeps those hospitals operating, has been a credit to their effort and to the ingenuity and innovation of those hospitals to allow that expansion and contraction to occur, when we just last fall had a tremendous peak that was at least 3 times what we thought was our peak maybe 8 or 9 months ago. And I only mention peaks because the statistics show that our cases seem to be on the rise again. I would not want to predict a surge. I hope that doesn't occur. But that is an important issue for our current very fragile healthcare system that was stretched financially in the last year. And as Tom Clark, the gentleman who spoke just before me, mentioned, this is a competitive market. We have insurance companies competing for their customers, and we don't have a concentration of 1 or 2 providers. We have major providers in direct competition, including, I mentioned at first, the University Medical Center as a public hospital, major anchor hospital, the HCA facilities, the Valley Health System, Dignity. In the north, we have Renown, we have Prime, and we have lots of non-major players that can be used competitively. So it is a highly competitive market. I think what this raises is that while the problems that have been identified are fairly representative, and I think clearly a problem that we have because it impairs access to healthcare, a rate-setting commission doesn't really address those problems. And I think that's why we are in opposition to this bill. There may be other ways to approach this, and I concur with Mr. Clark when he referenced both the study being done by the Patient Protection Commission and the All-Payer Claims Database that will begin to give the kind of data that's going to be necessary to evaluate how you make these changes. Professor White caught my ear as well from Case Western, and I think the points that Assemblyman Orentlicker and Dr. White made so cogently is that we can't compare Nevada to other countries. We have to compare our country to other countries, which suggests that the approach may need to be dealt with on a national level. We've had a change in administration. I think President Biden is clearly getting his feet on the ground. And I think the opportunity for the changes that we saw with even in healthcare, particularly in the Consolidated Budget Act that was passed, that generated, I can't remember how many trillions of dollars, and other actions that are taking place at the national level could very well provide some of the relief that will alleviate the problems that we're facing with a highly stressed workforce, a capacity crunch, which we're not quite in at this point, and hope we don't regain that. So I think the problems that we are dealing with are really more on a national level than a local. Contracting is always difficult. I respect that comment as well. We hear complaints about how difficult these negotiations are. So that doesn't suggest that these are being done by one-sided transactions. One person wins and the other person loses. These negotiations, they wouldn't be tough if they weren't being aggressively negotiated by both parties. And there are multiple parties to negotiate with. So I think this rate setting commission is an interesting idea, and certainly raises a lot of points to be discussed, but probably is not the solution at this point in time in the marketplace. Madam Chair, I'd be happy to stay on the line for any questions, but that, I think, concludes my comments at this moment.
Thank you. And with that, we will go last to Mr. George Ross. Go ahead.
Thank you very much, Madam Chair. My name is George Ross, GEORGEROSS, and I'm speaking on behalf of HCA Healthcare. First of all, I'd really like to compliment Assemblyman Ornlicker. He has put a tremendous amount of thought into this, and we really thank him for the amount of time he spent with the hospital industry going over his bill. And I would like to say that a super compliment because of the way he made the case for Medicaid rates. If there's one thing that would solve, not totally solve, but the most important improvement you all could make to healthcare in the state of Nevada is to raise Medicaid rates to those of Medicare. I've never seen a more persuasive case for it. I just hope it was more persuasive than have been over the last 2 decades, other than for last year's increase, for which we were very grateful. First of all, I would just echo Jim that Nevada is not Maryland, it's not Massachusetts. It doesn't have great teaching hospitals. It doesn't have a panoply of wonderful high-level doctors. It doesn't have massive access and quality. Instead, we're 45th or 50th in every single criteria, as Mr. Hillenbrand said. We're a growing state. What we have to be concerned with as we continue to grow is building more rooms, more beds, bringing in more doctors, providing more investment. That has to be, in reality, until we meet those needs, the number one criteria. We shouldn't be looking at bills that are going to retard and make that less likely. What we need to be doing is encouraging, not discouraging investment. Now, what's important here is this question of what costs are taken into account. Medicare only does cover 89% of the costs. We can argue, and I heard several times from Dr. White in particular, but implications from the sponsor, that those are pretty reasonable costs. In reality, there's quite a few costs that aren't there. And if a lot of costs that a hospital incurs are not recognized by that commission, and the return is based upon some of the costs, but not all of the costs, then the actual return that the hospital sees will be significantly less than a fair and reasonable return. And hospitals and investors make their decisions based upon their own costs, the way they read the costs and the return they see, not on the costs that a commission may see. I think that's pretty critical. We heard the sponsor over and over talk about, as well as his expert, about how this would be so good for consumers and customers of insurance companies. But there is not one thing in this bill that requires the insurance company to pass on any of those savings to the employers or the members or the patients. There is nothing in there to require them to reduce deductibles, to reduce copays, to reduce coinsurance. There is nothing in there even to make them pay the rates that the commission would set. We can't charge anything but that. We can't ask for anything but that. They don't have to pay it. And I would remind you all that a large portion of the payers in this state are in reality ERISA plans, over whom we have no control. So I think those are pretty critical points that I think is important. I would also like to point out just a little tidbit here that we were told that this would eliminate surprise billing. We already did that last year, so that's already done. Additionally, we're concerned about the composition of that commission. That has to be a very fair commission, has to be a very balanced commission. And if there are those on that, we have to have a way in this bill to appeal not just the commission decisions, because that's not in there either, or the timing of their decisions, or the timing of when we'll get their answer to the appeal. Time is money. The longer we have to wait with a poor return, the more there's something else, the more one is dissuaded from making investments. But we also have to have a way to appeal the members of that commission if in fact we believe they're strongly biased in one way or another. And then finally, I usually keep myself out of this as a person, but I will say that I have personal experience in the early part of my career in managing a group which kept oil companies refining and marketing from breaking the rules. We had a massive amount of rules of price controls. You end up spending most of your time figuring out how to be on board with the controls, how to make money out of the controls, less time on figuring out good investments. And finally, in terms of cost savings, we were told that we would be able to get rid of tons of administrative clerks. Well, I remember going through all these cost cutting, and if you have 100 bills and everyone is different, and you have 100 bills to 100 different entities that are exactly the same amount, nevertheless, you still have 100 bills. And you have 100 entities to whom you pay that you all have to keep track of. So you're not really going to save all that many people. But I would emphasize again that we look at our own costs. And finally, I just remind you that the role that Sunrise Hospital in particular plays in the community. We're the largest Medicaid provider in the state. 42% of our patients are Medicaid. Another 6%, sometimes 8%, are uninsured, which basically means they don't pay. And then we actually have, given the large Medicare customer base, we only have 16% commercial. That we have to get the money from those commercial customers to pay that gap. Now, I know Dr. Ornlecker thinks that this rate will solve that problem. And he also says, I want to reward efficiency, which we think we're extremely efficient. And he wants to reward severity of caseload, which we know we have a very comparatively high severity of our patients. So if we get a higher rate, significantly higher rate, to balance our poor mix, as well as our efficiency, as well as our severity, we'll be above the market and nobody want to come. It's our experience that despite insurance companies value what they have to pay at a very high level compared to other factors. And all of a sudden we'll be stuck with having to, if we can't go bargain. Today you can sit down and you can make a bargain with various companies and various payers and various plans and balance all the contents of that in such a way that they're happy enough to come to the hospital as a customer and we're able to get enough money to pay and fill that hole. Under this system, I have absolutely no confidence that would be possible. So again, Madam Chair, I want to compliment you and thank you very much for holding this hearing. It's been a very balanced hearing, a fair hearing. Everybody's getting a fair chance to get to say their piece on what could be one of the most important bills that, frankly, that I think I've worked on in my almost 20 years of lobbying in Nevada, actually 30 years of lobbying in Nevada. Thank you.
Thank you. And I wanted to give you the opportunity to correct yourself. I'm assuming that you didn't mean to say that our teaching hospitals here at UNLV and UNR were not excellent and not growing and not moving up in those standings, but that we just didn't have the number that like a state like Massachusetts might have.
We are doing very, very well. We are doing very, very well. No question about it.
Okay, with that, I'm going to go to the phone lines, and I will be limiting some of that testimony. I know that we have other members that need to get moving, and I know we may have some other follow-up questions based on that testimony. So at this time, if we can go to the phone lines in testimony and opposition, for the people on the phone lines, I would ask you to limit your testimony to 2 minutes. We've obviously had a pretty extensive presentation on opposition testimony, so if your testimony is very similar, please do not hesitate to say ditto or me too, or I agree with, what Mr. Hildebrand said, or whatever it is. We will mark your opposition in that way as well. So at this time, broadcast services, if we can go to the line.
Sure. To testify in opposition of Assembly Bill 347, please press *9 now to take your place in the queue. With the caller with the last three digits, 080, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Madam Chair. For the record, Susan Fisher with McDonald Carano, calling on behalf of Nevada State Society of Anesthesiologists and also speaking for the Nevada Society of Orthopedic Surgeons. We are testifying in opposition to AB 347. We appreciate the time that Assemblyman Ornlicker spent with us, but we just can't get there. No state has shown this provider tax to work, not one. Where it's been implemented, it's either been repealed or simply no opt-ins. After several Medicaid cuts over the last 12 years, including a massive 43% cut for anesthesiologists during the Great Recession, this tax provides little assurance that more cuts won't happen. The economy goes south, medical providers get cut, and the rates don't come back up accordingly when the economy rebounds. At a time when we're facing provider shortages, and certainly after the past year with provider burnout, this is not the time to introduce an experiment that has failed elsewhere into Nevada's already overstressed healthcare environment. We urge you not to process AB 347. Thank you.
Thank you. If we can go to our next caller in opposition.
The caller with the last three digits, 504, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, this is Dan Musgrove on behalf of the Valley Health System of Hospitals. That's DAN, capital MUSGROVE. I certainly won't be redundant, Madam Chair. I appreciate the last comment you made before turning it over to more opposition in that Nevada and this legislature, and especially hospitals, have worked very, very hard on expanding our graduate medical education program. The Valley Health System, including our Valley Hospital, runs about 75 medical students through our hospital every year, and we are looking to expand that program. I think you heard from Mr. Hildebrand that Nevada could become a place that physicians see as unfriendly. So we work on that effort to train those doctors, and then they end up leaving and heading elsewhere to pastures that are much greener. And we certainly don't want to get back to McCarran Airport being our healthcare facility of choice. I want to thank the chair for allowing us to testify, giving us so much opportunity, and absolutely the sponsor for all the time that he's put with all of us to try to listen to our concerns. Thank you for allowing me to testify.
Thank you. If we can go to our next caller in opposition.
Caller with the last three digits, 131, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Chair Nguyen, members of Assembly Health, my name is Connor Kane, CONNORCAIN, and I'm testifying today in opposition of Assembly Bill 347 on behalf of the Henderson Chamber of Commerce, and I promise I'll be quick with my testimony. I'd first like to acknowledge and thank Assemblyman Ornlicker and Ms. Johns for all their work on this issue over the past couple of months, which included a meeting with the Henderson Chamber. Unfortunately, the feedback that the Henderson Chamber has received on AB 347 is that it exacerbates existing problems in our healthcare system. Just quickly, one issue in particular to highlight is that the theoretical foundation of AB 347 is built on Medicaid rates being raised to Medicare rates, but the bill does not ensure that this will occur. I'll again conclude by thanking Assemblyman Ornlicker for his tireless work, but we are opposed to AB 347. Thank you.
Thank you. If we can go to our next caller in opposition.
The caller with the last three digits, 741, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Nguyen and members of the committee. For the record, my name is Brian, B-R-I-A-N, last name Cleven, K-L-E-V-E-N, and I am the Nevada Market Chief Financial Officer for Dignity Health St. Rose, which represents the only not-for-profit health system in Southern Nevada. I'm calling in opposition today to AB 347. I'll be quick and simply say ditto to most of to my colleagues and only add a few points in opposition of Assembly Bill 347. Two key points to reiterate. Medicare rates do not cover our costs, and there is no guarantee in this bill that the state nor rate commission would pay providers higher than Medicare rates, which is significantly concerning. And also the bill not providing a way to appeal or also address conflict of interest on the rate commission are massively concerning. In addition to previous testimony, there's many unknowns related to this bill, and it's extremely difficult for my team to determine the kind of impact it would have on the St. Rose system. But one issue alone I can speak to. If commercial insurance rates were set at Medicare levels, that issue alone would equate to a $183 million bottom line reduction to our market that serves the greater Las Vegas area. This could very possibly lead to elimination of needed service lines that we provide to the community and job elimination possibly for the very employees that saved lives in this state during the COVID-19 pandemic. In 2020 alone, which was an extremely difficult year with COVID-19 pandemic, St. Rose contributed over $154 million in community benefits. Because St. Rose is a not-for-profit system, any earnings that we have are reinvested back into the community to bolster Nevada's limited public health structure and pay for charity care. St. Rose has been doing the right thing in this community since 1947, and this bill would jeopardize our ability to adequately treat patients in our community. The Rate Setting Commission is wrong for Nevada. Thank you for your time, and thank you all for serving as elected officials during these trying times.
Caller with the last three digits. 655. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Joseph Heck, H-E-C-K, Red Rock Government Relations on behalf of the Nevada Osteopathic Medical Association. We called in opposition to the bill for all of the reasons previously stated by the other opponents. The only other thing I would add is that the use of non-economic med-mal damages as a potential benefit really would have no additional benefit, as med-mal non-economic damages are already capped at $350,000 in Nevada law as instituted by voter initiative in 2004. Again, we appreciate the Assemblyman's long-range vision to try to increase access and lower costs, but we feel that this bill is not the right way to go about it. Thank you.
We can go to our next caller in opposition.
The caller with the last three digits, 263. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Wynn and members of the Assembly Health and Human Services Committee. My name is Jesse Wadhams, Jessewadhams, representing the Vegas Chamber. And our Friday afternoon testimony today is we agree with the opposition and thank Assemblyman Ornlaker for his vision. Thank you.
We can go to our next caller in opposition.
Caller with the last three digits, 836. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Chair and members of the committee. For the record, my name is Jessica Ferrato, Jessica here today on behalf of the Nevada chapter of the American College of Emergency Physicians in opposition of AB 347. I'd like to thank Assemblyman Ornlaker for the consistent outreach and collaboration with stakeholders, and I'd like to echo the comments of my colleagues. I'd like to highlight a few items specific to emergency departments and physicians in the state. Emergency departments are the safety net of the healthcare system. We see patients no matter the severity or ability to pay. Medicaid rates are a constant concern, especially as the state continues to face fiscal challenges and recovers from the pandemic. ER physicians specifically are the most impacted by the low Medicaid rates throughout the state because we take majority of those patients, or all of those patients, even though ER physicians are positioned to benefit the most from a provider tax because we see more Medicaid patients than any others. We still have some concerns on how it will work in this bill. We are worried about unanticipated impacts to providers and patients. We have concerns that there aren't any hold harmless provisions available for providers to ensure that money is put back into the fund, that is put into the fund comes back to the providers in the form of increased rates. In terms of the Rate Setting Commission, we have concerns as well. Setting rates at Medicare during the pandemic or otherwise is problematic. There aren't any emergency doctors that can operate solely off Medicare rates. It does not cover costs. In addition, the wording in the bill around how this commission would raise rates appears subjective. Medicaid rates are a significant barrier for recruiting in Nevada, which impacts patient care. This comes in the form of provider shortages, long wait times to see a provider, and even wait times and availability for procedures. We're concerned about the impacts of the future healthcare system and look forward to continue to work with Assemblyman Ornlaker on this policy moving forward. Thank you.
can go to our, I'm going to take a couple more callers, so if you can be brief, then you will allow for other people to do it. If we can go to our next caller in opposition.
Caller with the last three digits, 679. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Wynn and members of the committee. This is Gabrielle McGregor, GABRIELEMCGREGOR, from the Ferrara Group, representing the Nevada Resort Association. The Nevada Resort Association is in opposition to AB 347, and in the interest of time, I'll just say me too. Thank you.
Best testimony yet. If we can go to our next caller in opposition.
With the caller with the last three digits, 139, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Thank you, Chair Wynn and committee members. Misty Grimmer, GRIMMER, with the Ferraro Group representing North Vista Hospital. We are before you today in opposition to AB 347. We appreciate the open door and multiple meetings that Assemblyman Orrin-Lichter has had on this bill, getting input from the industry, and appreciate the shared goal of getting Medicaid reimbursement rates increased in Nevada. However, we do not believe the provisions of this bill will achieve that goal and will ultimately end up increasing the cost of health care to the citizens in Nevada. The design of the Rate Setting Commission in this bill only puts restrictions on one portion of the healthcare market, putting the hospital community at a disadvantage. Others have already addressed the issue of cost, so I'll just say we echo those comments. North Vista is not a large hospital, but we are the only hospital located in North Las Vegas. And unlike other hospital systems with multiple locations in Las Vegas, we just have one campus. This means we don't have as much ability to make up in volume what is lost from one service to the next. The ability to negotiate with our fellow providers and the payers is important for a small player. Thank you very much for your time, and we respectfully request that the committee not process this bill. Thank you.
I'm going to take our last caller in opposition. Again, I would encourage all of those people that are potentially still waiting on the line to submit their written comments in opposition. And even those that were on the line, they can do the same as well within 24 hours of today's hearing. So if we can go broadcast services to the last caller in opposition.
With the caller with the last three digits, 503, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon. My name is Chris Bassey. B as in boy, O, S as in Sam, S as in Sam, E as in egg for the record, representing Renown Health. Good afternoon, Chair Wynn and committee members. First, I appreciate the Assemblyman's openness to share ideas and hear concerns about this bill. However, we are still opposed to AB 347. Rate setting for healthcare providers and hospitals is not the right solution for Nevada. So at this point, I think the majority of my points have been made, so me too. I just think at the end of the day, given this bill doesn't really provide a mechanism to achieve the goals that were originally stated to reduce costs at the consumer level, because it doesn't ever get to impact the payers, the bill only puts access to care in Nevada at risk. Renown is a private, nonprofit, locally owned and operated integrated delivery system, primarily located in Washoe County. And we strive to continue to meet the needs of the communities that we serve. Rate setting in the short term will impact our ability to expand capacity and services to meet the growing needs, and in the midterm will likely impact our ability to care for patients. Thank you for the opportunity to participate today.
Thank you. And with that, I'm going to close testimony in opposition. I am going to open it up briefly for testimony in neutral. I think we have a couple of people on the line. I will remind people that neutral testimony is not taking a position on the bill, either for or against. It is truly neutral testimony. Broadcast services, can we go to neutral testimony?
Testify in neutral to Assembly Bill 347. Please press *9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
Do we have any people on the Zoom in neutral? If you are, I'd ask you to unmute and turn on your camera, but I don't see any. So at this time, I will close testimony in neutral of Assembly Bill 347. And at this time, like I said before, I will open this up. I have only received a couple of messages from people with some follow-up questions based on that, or they may have questions for our bill sponsor or potentially any of the witnesses. I believe I got one from Assemblyman Hafen.
No, Madam Chair.
Never mind then. I'm just kind of doing a brief look here. Do we have any follow-up questions? No. Okay. With that, I will turn this back over to Assemblyman Orenlicker and his co-presenters for any closing remarks.
Thank you, Chair. Thank you, members of the committee. Professor White, or would you like to say anything? And our other co-presenters, if you'd like to add some concluding remarks.
Yeah, I'd like to say a couple of things.
Oh, can I get you to say your name before you speak?
This is Joseph White, a witness. So I'd like to say a couple of things. One is that there is very, very strong evidence that there are substantial extra costs in the American healthcare system, including Nevada, associated with billing. It is not the case that sending out the same number of bills when the bills are all by the same rules is just as expensive as sending up that number of bills with extremely complicated different rules about what the bills involve. If it were the case, then the amount of billing effort in the United States and Canada, or the United States and many other countries, would not the amount of billing expense would not be so different. So I do think that there are savings to be had, and those savings related to the administrative cost and the complexity of the billing are in the range of 5 to 10% of cost by most of the studies that have been done. There have been studies that show, for example, that the average American physician practice per doctor is spending about $80,000 a year on billing, compared to, and it's just much lower in other countries. So there is a savings, there are inefficiencies there. The question is there, and given that we spend so much more money than other countries, we should be looking for a way to get those savings. And the most obvious way to get those savings is with standardized prices and all payer payment. Now, I cannot speak to the questions of the shortages of physicians in Nevada. And that is for you guys to think about and what the reasons are for that. Right now, I think it is true that costs per capita in Nevada are lower than in a lot of other states. Costs per capita for physician services, however, are not. They're about the same, the average in other states. They're lower because of things like, for some reason, hospital payments, and for some reason, some of the other services like home health. I don't know why that is. And I do think that there's an important point made here about thinking about the different providers that are involved, whether we're talking SNFs, home health, and so on the Medicaid side, and thinking about the different providers that are involved with other aspects of healthcare. I do think it's important to remember that a whole lot of employer-based healthcare is ERISA plans. And logically, if costs are lower for employers, maybe they won't pass it on, but it's not a matter of their negotiations with insurers, because they are simply experiencing the costs directly, and the insurers are simply processing for them. So I think that you need to think about how the ERISA plans really work out on this process. So there's a lot to think about. I think there are questions to legitimately ask about supply, and also about what is going on with Nevada costs on the whole. Nevada does have a very low number of doctors per capita. It also has a relatively younger population than most states, but not in line with the number of doctors. I think there are significant questions about what attracts doctors. I think it's possible that having a system which is much less of a hassle for doctors in terms of dealing with the billing and dealing with the cost structure of in practices would logically mean that it would be easier for doctors to be in smaller or solo practice compared to what's happening now, when they need these, when they're selling out to larger practices in part to handle the billing and all that. And I think it's important to remember that there's savings out there relative to any other system that would seem like a good idea to find some way to capture.
Thank you, Mr. White. Assemblyman Ornlicker, do you have any final closing remarks?
Yes, thank you, Chair Nguyen. Thank you, members of the committee and all the stakeholders who worked with me over the past few months and spent much time letting me discuss this with you and providing me your feedback. I'd just like to say a few things in response to some of the comments from the opponents. There were some things that are just not accurate representations of the bill, but the couple of things I want to talk about specifically, Jaron Hildebrand from the State Medical Association was concerned about whether the provider tax would be equitable. And his concern was that not all doctors see Medicaid patients, so they pay the tax. And it is true that the only way you receive money back, and remember, it's a 3-to-1 return. That's guaranteed. That's not speculative. Every dollar the providers put in, $3 comes back. But it only comes back if you take care of Medicaid patients. To me, that's a very good thing in terms of equity, because it says the more you see Medicaid patients, the more you're willing to provide care to the neediest among us, the more you'll get paid. And I think that's good. It provides an incentive to see Medicaid patients. And for those doctors who are in a specialty or a location where there just isn't an opportunity to see Medicaid patients, then one way to meet their responsibility to share in the care of Medicaid patients is to pay toward their care if they can't provide the care themselves. So I think in terms of equity, this is designed very well. Jim Wadhams for the Hospital Association suggested that the healthcare market is a competitive market. That's at odds with the understanding of every health economist that I'm aware of. The reason why we need this rate setting commission is because the healthcare market does not operate like a competitive market. We have excessive prices. We have these highly varying prices. Nobody thinks in the health economics world that this is working properly, and that's why we need government intervention to correct the market failure. So I'll say that in terms of what we're offering providers and patients, what we're saying is we want to ensure that all providers are fairly compensated, they cover their costs, they earn a reasonable profit, and that means that there will be providers available for patients. We're saying to providers, we will eliminate all this administrative complexity that Professor White talked about. You don't have to have all these negotiations. You don't have to spend hours a day filling out different forms for different providers and doing all these different negotiations. And we will provide you stronger protection against the threat of professional liability. All those things that are important that I've heard over the years from healthcare providers. We want to be fairly paid. We don't like to deal with the administrative paperwork and bureaucratic hassle, and we want to be protected against unfair malpractice litigation. All those things are in the bill, and the only thing that they don't get is the ability to charge excessive profits. We don't want them to gouge patients, and that's the only thing they don't get out of this bill. So again, thank you very much for your consideration, and I look forward to working with everybody to move this forward.
Thank you, Assemblyman Ornlicker, and thank you, and I know you probably goes without saying, thank you to the committee. I know that this was a extra long hearing, but I think it is a very important policy topic that we need to have these kind of conversations. And I appreciate everyone's patience with me trying to have like an actual policy conversation in this virtual setting. Obviously, the 81st session flexibility and accommodations have been key. So I appreciate that. And with that, I will close the hearing on Assembly Bill 347. And at this time, I will take comment. I will go to public comment. I don't know if we have anyone in the public comment line, but broadcast services, can we go to public comment? I will remind everyone to please clearly state your name for the record, as well as limit your testimony to 2 minutes. And I'd remind everyone that I know that there were some people that did not get the opportunity to testify during the opposition time period. I would note that this is not the time to rediscuss the bill. And if you do have written comments, I would very much encourage you to submit those written comments. And so with that, broadcast services, can we go to the line and public comment?
To provide public comment, please press *9 now to take your place in the queue. And just so you know, Chair, we did get through all the callers in opposition today.
Oh, wonderful. Thank you so much. I appreciate you stating that for the record. I was concerned. It was good timing then. But public comment, do we have anyone on the line for public comment?
The public line is open and working, but we have no callers at this time.
Okay, with that, I will close public comment. We have a meeting on Monday. It'll be another crazy week. I don't anticipate us having to have any night or additional meetings in HHS. Fingers crossed. Hopefully I didn't just jinx myself, but I want everyone to keep in mind there are a lot of work session documents, so please try to do your best to respond to committee members' emails about any concerns that you have about their bills, and we will move forward. With that, have a wonderful weekend, and the meeting is adjourned.